in the most simple manner so that it can be performed by most surgeons. And Deepak sir will be demonstrating functional endoscopic sinus surgery next, followed by endoscopic septoplasty. I'll be starting off with the external septoplasty via the rhinoplasty approach. I think I hand over the proceedings to the stage.
Okay, so Prashant, are we ready? Can I go ahead?
Yes, sir. Yes, sir. You can go live.
Yeah.
Keep 15
So,
number.
Namaskara,
I want to see the
hello, and good morning to one and all. Myself, Bhalchandra Joshi. I'm marketing head for Surginova division, makers of Joseph CV, Enzoflam, and Nulog D. At the outset, I take this opportunity to welcome you all to this exclusive live surgery workshop, Surginova ENT Rhinology, in association with NEED, in which we are going to see exclusive surgeries by expert otolaryngologists live from Raja Rajeshwari Medical College and Hospital, Bangalore. So when I take you through this agenda, you can see a feast of 3 back-to-back surgeries, academic feast, surgical feast, you can say. So first surgery would be performed by Dr. Vishwas KV on septorhinoplasty, followed by Dr. Deepak Haldipur sir, who will be performing functional endoscopic sinus surgery, FESS, followed by Dr. Naveen, who will be conducting the endoscopic septoplasty, and followed by 2 lectures by Dr. Rajiv and Dr. Ashish Rao. I take this opportunity to introduce our Dr. Deepak Haldipur sir. He is an expert surgeon, dynamic senior ENT, head and neck surgeon of repute, hailing from Bangalore, director of Trustwell Hospitals, Bangalore. He has internationally renowned ENT surgeons with more than 3 decades of experience. His skills includes cochlear implants, endoscopic sinus surgeries, microsurgeries of ear, rhinoplasty, thyroid surgeries, and head and neck surgeries. He is also honorary professor at Raja Rajeshwari Medical College and also visiting faculty to various hospitals in Bangalore. He also runs biannual courses in Bangalore at Advanced Cadaver Lab at MS Ramaiah Hospital, Bangalore. Dr. Deepak Haldipur sir is a passionate educator, as we all recognize him, performed various live surgical demonstrations at medical colleges and conferences. Dr. Deepak is having honorary consultant to Indian Institute of Science and is personal ENT surgeon to Bharat Ratna Professor CNR Rao. Dr. Haldipur is member of various prestigious professional associations like Indian Society for Otology, Association of Otolaryngologists of India, Indian Society for Rhinology, Sinus Endoplastic Society of India, and Cochlear Implant Society of India. He has numerous publications to his credit. So welcome, Dr. Deepak Haldipur. Our next expert surgeon, Dr. Vishwas, who has done his post-graduation in England. He is fellow Commonwealth, MIMSA board certified facial plastic surgeon. He is currently practicing at Bangalore with more than a decade experience in handling complex aesthetic and reconstructive surgeries in head and neck. He has international board certification and Commonwealth fellowship in facial plastic surgery. He is academically very active in training future plastic surgeons and in art and science of cosmetic surgery since last 8 years, and also visiting faculty to Yanapova and Manipal University. Founding member of Indian Facial Plastic Body, Dr. Vishwas has authored many manuscripts and had chapter contributions in facial plastic surgery and otolaryngology. Welcome, Dr. Vishwas. Our third expert surgeon, Dr. Naveen Krishnamurthy. He has done his post-graduation from KIMS Hubli and practicing since last 16 years as head and neck surgeon in Rajajinagar, Bangalore. He has been member of Indian Medical Association, Association for Otolaryngologists of India. He has fellowship of FESS and otology under Dr. Kirtane and presented more than 9 papers across various conferences and 3 research publications. And now I present our esteemed moderator panel, which includes Dr. C.V. Srinivas from Bangalore, Dr. Harihara Murthy, from Bangalore, Dr. Srinivas V again from Bangalore, Dr. Islam from Srinagar, Dr. Shashidhar from Gurgaon, he has already joined us. Welcome, Dr. Shashidhar. Dr. Sanjay Agarwala from Indore, Dr. Jayaprakash from Karnool, Dr. M.N. Bhattacharya from Calcutta, and Dr. Sonali Pandit from Mumbai. So this is the whole esteemed panel of moderators. I also welcome all the dignitaries of Raja Rajeshwari Medical College, including Dr. Nagaraj, who is the head of the department of ENT department. And I'm sure this workshop is going to be a unique academic feast to all of us by eminent experts and will enrich our knowledge and surgical skills. I must mention here that this program is recognized by Karnataka Medical Council, and close to 700 registered delegates are watching this program live. We also have 15 streaming centers at various medical colleges also who will be watching this event live. So I wish Surginova 2021 a grand success. And now I hand over this session to Pavitra and Akila to brief us on the first surgery. Thank you. Thank you so much.
Thank you, sir. A very good morning to one and all. I am Dr. Sarasa Akila, Junior Resident of ENT Head and Neck Surgery. I, on behalf of the HOD, the staff and the ENT department, extend my warm welcome to all the participants attending Surginova ENT Rhinology 2021, a live surgical workshop at Rajarajeshwari Medical College and Hospital, and also warm welcome to all the online participants. Today's first session is going to be septorhinoplasty. The moderators are Dr. C.V. Srinivas, who has done his MBBS from BMC, DLO from MMC, DNB training MSRMC, and MS from KIMS. Fellow in Otology, Paris. Post held by him are AOI Bangalore President and past Secretary. The AOI Karnataka, past Secretary and past Treasurer. AOL South Zone Secretary General, Editorial Board Member, IJLO for 2 years. AOL currently EC Member, National Body. Past Honorary Advisory Board Member for CIMS known as REF-RX. Authority for more than 20 articles in various journals. Editor, Karnataka State ENT Journal. We also have Dr. Shafqat Islam, who is from Srinagar, is currently not joining this session as there is a curfew in Srinagar. The other moderator for this session is Dr. Shashidhar TB, MS ENT ECFMG from USA, Artemis Hospital, Gurgaon. Dr. Shashidhar TB is the head of the Department of ENT of Artemis Hospital, Gurgaon, NCR. He serves as senior consultant, catering a wide range of surgeries, pediatric otolaryngology, with specific interest in complex laryngeal, tracheal, and bronchial reconstruction, with sudden sensory neural hearing loss, tinnitus, and head and neck cancer surgeries. His association with Ayush for more than a decade inclined towards integration alternative medicine with otolaryngology, several national and international publications to his credit. He has featured in leading newspapers throughout the country for managing unusual cases of spontaneous bleeding from eyes, difficult airway reconstruction in children and adults, and saving army men after choking on kebab. He is member Association of Otolaryngologists of India and Laryngology and Voice Association of India. Today's expert session is Dr. K. Vishwas sir. Coming about the case for today, a male patient of 20 years has presented to ENT department hailing from Bangalore with a history of right-sided nasal obstruction and difficulty in breathing since 2 years. And he had a past history of trauma to external nose during his childhood. Clinical examination, septum is deviated to right side, tip raising, caudal deviation to right side, face is symmetrical, intercanthal distance is equal to the alar base. There are no wrinkles. External framework, middle 1/3 is deviated to left side. Nose length is 4 centimeters. Nasevion to tip is equal to stromium to mentum. Tip projection, alar facial groove to the nasal tip is equal to 2.5 centimeters. No tip rotation. Brow tip line, lateral aesthetic line deviated to right side. Columellar show is seen minimally. Otil's test, no improvement seen. Olfaction is decreased. There is decreased perception of smell on the right side. This is a pictographical representation of the preoperative assessment in aesthetic views. This is a video showing preoperative diagnostic nasal endoscopy. This is a right side. The DNA was done after packing. Right side, we find caudal displacement of the septum, and choana could not be reached in view of gross TNS. And this is the view of the left nasal cavity, showing compensatory left inferior turbinate hypertrophy with mild congestion of the septum. And here we can see the choana. Thank you. Over to OT.
Good morning to the moderators, C.V. Srinivas sir, our senior, and Shashidhar TB from Artemis Hospital, Gurgaon. Welcome to all the audience who are here, joined in on a Saturday morning, watching us live. Thank you for your time. Can you play the slide of the patient with the frontal view and the profile view and all that? Yeah. Dr. Akila, can you play that slide so that I can show it? Yeah. So this patient had a early childhood trauma, after which he's had a nasal obstruction for a very long time now. And now after he turned 20 years, he came for a surgical correction. Now, if you can see my screen, just focus on the screen, please. Come to the front. Now, this surgery here has been planned for a improvement of the nasal passage via the rhinoplasty approach, for the reason that he has a deviation at the K area as well as a deviation in the cartilage and the bone. Now, this could be done with a septoplasty approach, conventional septoplasty approach, but the patient did ask for a correction of the aesthetics also. But for the purpose of the workshop and to keep it rhinology based, herein I will be handling the septum in quite a detail today. Obviously, all of you are doing septal surgeries. I will try to explain what all areas and points to be touched upon for getting a straight septum for an aesthetic nose as well. Now, looking at the frontal view, here we have put photos of both the patient with his beard grown and his beard not grown. It is better to take the photos of the patient without his beard. The reason being the measurements between the horizontal thirds, that is from the hairline to the nasion, nasion to the subnasal, and subnasal to the menton should be equal. But if you look at the beard, it looks as though the nose is short. So this is an apparent illusion, and that's why you need to make sure that the patient has his beard shaved when you actually ask for the photographs and do the analysis. And looking at the patient now in the frontal view, what you can see is his left side of the face is more wider, whereas the right side of his face is narrower. This is an asymmetry that is there possibly from birth, and this is what you need to bring to the patient's notice, because that's what the patient will notice after the surgery. So please do make sure that, please focus both these things, please. Yeah. You can see that the left side is more wider and broader. And now you can see that the brow is quite heavy, and the brow being quite heavy, what happens is the patient, in order to draw the attention to the rest of the face and make it look angular, he tries to grow a beard for better aesthetics. Otherwise, he has a very rounded face with a flat chin. And this is not very attractive, and that's why many people try to grow a pointed beard. Now, the reason to have a sideburn in many people is to give a definition to the face. It is like having a picture frame wherein you border the picture so that we concentrate on the painting. So it is something like this. Getting a good eyebrow and a good eyelash is to highlight your attention on the eyes. Similarly, getting a good hair beard line is also to highlight your attention on the face. Now going to the nose per se, if you can see in the frontal view, the brow tip line, there is a line which comes down and then it goes to the tip. You can see that the brow tip line is broken. Okay, please focus. Don't focus me. I don't need focus here. Focus on the patient, please. Yeah. You can see that there's a breakage of the brow tip line. That definitely means there is a deviation right at the K area. And you can also see, if I block off the lower third of the nose, that the upper nasal bone part is also tilted to one side. And you can see that the cartilage is tilted to the opposite side. There is a classification by Professor Yongju Zhang, and in this classification, a deviation of the nasal bone to one side and the cartilage to the other side is usually a type 1 or a type 2. If the tilt is only straight, then it is a type 1. If the tilt of the cartilage is C-shaped or curved, then it's a type 2. So herein, for an aesthetic correction, we need to be obviously correcting the nose, nasal bone part, K area part, and the cartilage. But for the breathing per se, if I correct the central portion of the septum, which is actually opposite the inferior turbinate and the middle turbinate, that should be sufficient. So for the purpose of demonstration, I will be going ahead and showing the septal part mainly, and then completing the surgery with the aesthetic corrections. Now, the other things to notice are the radix area is quite deep. And if you come down, there is a broadening or convexity at the K area and concavity on the left side. And as you come down, there's a prominence on the left side near the upper lateral cartilage, possibly being prominent, or it could be a lateral crural malposition where the lateral crura is moving towards the medial canthus and not towards the lateral canthus. Now, the columnar show, or rather the nostril show, seems to be adequate enough. The tip seems to be single point. It doesn't seem to be boxy enough. The width of the eye and the width of the alar base seem to be adequate. And this is what I can notice in the frontal view. Next slide, please. Next
Dr.
slide.
Vishwas, for the benefit of younger colleagues, can you tell them what is the K area for the benefit of the younger colleagues?
Yes, sir. So the K area, as you can see here, focus please, is the keystone area. It is that central pillar on which the whole nasal architecture stands. It is something that supports the nasal bone as well as the nasal dorsum. And that area, if we disturb, it's likely that the saddling will happen and the patient will have a depressed nasal dorsum. Now, this is the profile view. And in the profile view, you can see that the radix is deep. And usually the radix should be starting off at the supratarsal crease for a good long nose. The profile, he has a small hump deformity that you can see. And the tip seems to be adequate. Only thing that the projection is not adequate. And there's a very, very slight rotation of the tip, possibly 100 degrees or so of the nasolabial angle. The nasofrontal angle is also obtuse. Now, if you look at the projection vis-a-vis the bearded photograph, you will feel that it is under projected. But if you see it without the bearded photograph, you will see that the projection looks adequate, but of course it needs to be augmented a little more. So this is something I was mentioning earlier. And if you compare the right and the left, you can see that the left side, the cheek is more sloping as the cheek on the right side, which is more curved out. And coming to the columella, you can see that there is a columella show of about 2 to 3 millimeters, and there is a good definition of the soft triangle. However, you can see that the supratip area looks a little bulky here. That is only for aesthetic outcomes. Now, a good projection will be required here. Projection means bringing the tip forward, which I'll explain to you as I go in the case. Next slide, please. Next, please. Yeah. Looking from the skyline view, you can see that obvious deviation we did mention earlier, going to the left of the nasal bone and then the cartilage going to the going to the right, the nasal bone, and cartilage going to the left here. Same thing in the basal view also. The basal view, what you should be noticing again is the widened left face compared to the right face. And you can also see that the columnar alar ratio, there is a shortening of the alar point. The columella is also short. So if you project it higher, if you bring it higher, so then the ratio will be adequate and the triangle will become an isosceles triangle. Next slide, please. Yeah, I think this should be the basic analysis. As I go inside, I'll explain more. I think we'll change to the camera, VTOM camera, please.
So that was a very good description of the asymmetries and dissimilarities in the patient.
Yeah.
So Dr. Vishwas, can you start off with what are your anesthetic expectations? What all things you have asked your anesthetic in terms of blood pressure and vitals and position before you just start off the case?
Yes, sir. I will hand over the mic to our HOD of anesthesia, Rangalakshmi ma'am, who will be speaking about what has been done for the anesthesia requirements. As she gets onto the mic, I will just explain what I have done for infiltration. I have mixed a solution of 2% lignocaine with adrenaline with 0.25% bupivacaine, 5 ml equimixtures, madam, equimixtures, and infiltrated in the subperitoneal and the subperiosteal planes on the nose by going in a single point from the mid-columnar area. Then I've infiltrated the soft triangle and the area over the lateral crura, and I've infiltrated into the columella and the septum infiltration at the various points to be blanching it. This was done about 25 minutes earlier to make sure there is adequate vasoconstriction and hydrodissection. Over to you, ma'am.
Dr. Vishwas?
Yes, sir.
What is the maximum volume did you use? What is the maximum volume of your solution did you use?
7 ml, sir.
How much volume did you use?
7 ml.
Including
So
both
about,
sides and the dorsum.
Yes, sir. About 3.5 ml of 2% lignocaine with adrenaline. That's a ready mixture that we are using.
Absolutely. Okay.
Vishwas, Dr. Srinivas here.
Sir, good morning, sir.
Good morning. Due apologies for my late arrival.
No worries.
Now it's in Bangalore.
Yes.
So, and all the other people who are coordinating on the session. Very good morning to all of you, sirs. Nice to be back here, Vishwas.
Yes, sir. Very nice to host you here at Rajajeshwari, sir.
Thank you so much. My pleasure. Can we take on with a little bit of the local anesthesia? Do you use the local anesthesia as 3 to 5 milligrams per kg body weight for lignocaine?
Yes, sir. That's the ideal dosage which we keep within. So his weight is 64 kgs.
Yeah.
So I've kept it within the range, sir. 3 ml per kg body weight is what we keep it. Sir.
And
3 mg
you
per- 3
also
mg per
added
kg.
sensor, that is bupivacaine.
Yes, sir.
Okay. Okay. I think our madam should throw a little light on that. Increased levels of bupivacaine could be neurotoxic or cardiotoxic kind. Madam could throw a little more light on that.
Sir, yes, sir. The mic is with her now. Ma'am will speak, sir. Rangalakshmi, ma'am.
Good morning, doctors. It's a pleasure to be with our colleagues in and I'm Dr. Rangalakshmi. We have a team here, anesthesiologists and postgraduate students. And sir, you want me to clarify about the local anesthetic, or first you want me to talk about what we did for this patient here?
A point about the local anesthetic first and then what we did for the patient.
So I think Vishwas, you have given bupivacaine local anesthetic.
Bupivacaine with 2% lignocaine adrenaline.
Look,
Mixture.
2% lignocaine adrenaline. So when you mix bupivacaine with 2% lignoadrenaline, what happens is both the anesthetics dilute each other. So the bupivacaine dilutes the lignocaine and the lignocaine dilutes the bupivacaine. 1. 2 is that the lignocaine, the maximum dose with adrenaline, we can go up to 7 milligrams per kilogram.
Yes.
And the bupivacaine is up to 3. Now, remaining, because adrenaline actually makes it safer. And earlier there was this, the risk of inhaled anesthetics reacting with adrenaline and the sympathomimetic action on the heart and, sensitize, we say, the myocardium to sympathetic effects of the adrenaline. But now the local inhaled anesthetics we use are totally safe, and any amount of adrenaline can be used with them.
Isoflurane
Regarding
and
your
sevoflurane.
toxicity, yeah, we are using sevoflurane.
Sevoflurane, yeah.
Yes,
the
we are
safest,
using sevoflurane. We
inhalational
have-
anesthetist.
Yes, we are using
Anesthetic.
sevoflurane in this patient. Sevoflurane also helps for hypotensive anesthesia, which may be needed for this procedure. The other, your question about toxicity, the lignocaine, bupivacaine does have a slightly higher chance of cardiotoxicity than the neurotoxicity. However, the doses which these people are used are quite low. So we have not had actually any, in my 25 years of practice, I have not seen a single patient who has had a local anesthetic toxicity because of ENT infiltration. It can happen while we are giving due to inadvertent intravascular injection. The only thing which we should be careful about is, at least we anesthetists always aspirate before injecting anything, so that be sure you are not in a vessel anyway. That's all we take care about.
Thank you, ma'am. Thank you for the clarification. I just raised this point because we've had a couple of cases where we had some kind of issues.
Okay.
And in that particular case, there was infiltration of lignocaine with bupivacaine with a botropase, which acts locally as a vasoconstrictor.
Yeah.
So just, for all those people to take home the message, what to do and what not to do was the idea of this question.
Yes, I would say a very safe bet is to tell the anesthetist the dose of the local anesthetic you are infiltrating, and aspirate before infiltrating the wherever you are doing it, so
Thank
that
you,
you are
ma'am.
not inadvertently in any vessel.
Thank you, ma'am. Thank you. Vishwas?
Yes, sir.
Dr. Alakmi, can you quickly go over the blood pressures and the vitals, and how are you maintaining the heart rate and MAPs?
Yeah, just a minute. At present, see, we normally give hypotensive anesthesia for all the ENT procedures as and when the surgeon wants it. A word about hypotensive anesthesia and word of caution about that also. Our surgical colleagues want hypotensive anesthesia in, I can understand that they have a very clear surgical field and all of that. But hypotensive anesthesia actually is related to the preoperative blood pressure. And we call it hypotensive when the blood pressure is, or rather the mean arterial pressure is reduced to about 30% of the preoperative reading. 1. 2 is hypotensive anesthesia, always a word of caution, because severe hypotension, that is when the MAP goes below 60, there is a problem in the vital organ perfusion, that is the heart, the brain, and the kidney. As such, hypotensive anesthesia for long procedures is associated with a little bit of oliguria, which they say is reversed, again because of the action on the glomerular filtration rate. The hypotensive anesthesia in this patient we have induced with propofol. We have given a good dose of fentanyl, which is about 100 mics. And then we have started a dexmedetomidine drip of 0.5 microgram per kilogram per hour. So this is the dose which is going. This is a standard we use. There are, however, we are also supplementing with sevoflurane. The blood pressure is 80/50, as you can see, and the pulse rate is 52. Show me the pulse rate monitor. Yeah, it's 57 now, with a saturation of 98. And that is the ETCO2. Please show that side of 31.
This is as perfect as it gets.
I beg your pardon?
So we'll quickly move on to the surgical part, Dr. Vishwas.
Yeah,
I
sure,
think we are
Thank you so
lagging
much.
a bit behind. So can you start off with the surgical part, the incisions and
Thank you.
Thank you.
Thank you, Dr. Lakshmi. That was a really informative talk from your side.
Thank you.
Thanks to the anesthetist team by Dr. Ranglakshmi ma'am, our associates, Dr. Suraj, Samir, and Chris, who have given an excellent anesthesia. And you can see the pulse rate and BP well under control. So without much delay, now I'm going to go transcolumnar, the broken line scar, to make sure that when the scar heals, it is not seen too obviously. And on retracting the tip, you can see that there's a caudal dislocation to the left side. That means there is a fracture line and then it is moved to the opposite side. So keep the scissors ready. So the way I do it is I take the 15 number knife, an inverted V incision. I go stab incision first on the vertical part of the 1V. So once the stab is done, I go to the opposite side. Get me another knife, please. And again stab. I just make sure I don't go too deep, because you need to be sure that you're only cutting into the skin and the subcutaneous tissues. Then you go onto the horizontal line, which you have drawn right onto the margins. Again on the opposite side. As I am doing the surgery, you can see that I am moving my fingers to allow the reflection of the incision lines. So now I am dropping the vertical line from the soft triangle right onto the horizontal incision, which I have made earlier. Same thing on the opposite side. I drop the incision from the soft triangle right onto the horizontal line. So all this is done without much force. Angle scissors, please. So that you cut only the skin. Angle scissors, please. Only the skin and not the underlying cartilages. So once it is done, you tunnel underneath using your scissors onto the V point where you emerge out. Get the 11 number knife, please. The reason to do it is now you're protecting the cartilages underneath, and then you complete the cut with the 11 number knife. Either you or your assistant can complete the horizontal first. Don't try to cut in one go, because you can tend to damage the whole incision. So just go small snip by snip. Hold it, hold it. Yeah. You can see how I'm supporting the knife and then cutting onto the knife so as to emerge at the point as is required to expose the underlying cartilages. There's a small attachment there. I'm trying to release it by the 11 number blade. So now widen your scissors. Again, opposite side. Again, tunnel. See how I am moving with small movements with the knife, with the scissors. Go underneath the skin. Come out at the V point. Keep your scissors in that position and run your knife upwards. The blade should not be running downwards. It should be running upwards so that you do not cut inadvertently into any of the tissues underneath. So I'm using the 11 number knife and just running on the scissors. Okay. So once this is done, you can widen this. Now you can see that the split has been done. Just underneath that, you will see that there are columellar vessels. These are the columellar vessels that you need to be cauterizing. Make sure you have very thin cautery points. Keep the skin hook ready. Yeah, cautery please. Yeah. So keep your cautery settings very low at 10. Herein I've kept the cautery settings quite low. And if possible, just go underneath that columellar vessel and buzz it. Make sure your skin is not cut. So once it is done, and once you have cauterized both the blood vessels together, just go again. There sometimes might be a second layer of deep columellar vessels. And this is the vessel that can bleed and trouble you repeatedly. Cautery, please. Yeah. So one thing is you need to have
a little more brightness on the camera, please. It's very dark.
Is it, sir? Light source can increase. It is at 60%.
Visible to you, but for us the image is a little bit more. Yeah. So you should can
light source of the
be
camera. Yeah. One of you hold this gently.
Yeah. Now
Just hold it
it's
gently.
better.
Just hold it gently. Give that. Take another skin hook. Hold, sister. Take another skin hook. Another new one. Yeah. So now what I'm doing is I'm wanting to see the medial crura. So I'm with the scissors, I'm sitting on the medial crura and slowly extending the incision right onto the soft triangle. Herein you can see that there are some more layers. Can you see this? And these layers need to be adequately cauterized before you go and expose the Did you get the other skin hook, please? Yeah. So with the skin hooks, what I'm trying to do now is to pull the edges up so that I can get exposure to the wet gauze, please.
Yes, now we see it very clearly. The cartilage is just barely visible there.
Yes, sir. Cautery is being pressed. Don't press the cautery. Yeah. So here you can see the medial crura on this side, and this is the medial crura on this side. So what I do is run with the scissor itself onto the intermediate crura and then follow the lead of the medial crura by sitting down on it to cut into the soft triangle. Same thing on the opposite side. I sit down on the medial crura and then slightly widen it out. I think you can see the medial crura here. Can you see, sir? This is the medial crura. Is it seen?
It's visible.
Yes, sir.
Yeah.
Then I run on it and then use the platform of the medial crura just to cut at the soft triangle. I hope it is visible, sir.
Yeah, it's visible, but
It's
I think
visible.
the camera adjustment should be a little more better.
The
So that
camera needs little high on their gamma or something, which inherently is like compensating with too much of darkness. Yes, now we can see.
So all these attachments are the skin to the intermediate crura attachments, and that needs to be released closer to the cartilage, please, rather than away from the cartilage. So once you have released this, and this is the intermediate crura that can be seen, try to get your skin hooks to pull the soft triangle. Ella, retract it to me, please. Cautery, sister. So what I do now is I pull the intermediate crura. Hold, one of you hold. Ella, retract it to me, please. Hold your Ella retractor and get the exposure of the lateral crura, and using the reflection of the scissor itself, keep going subperichondrial plane and go on cutting it to expose the lateral wing of the lateral crura.
this
Dr.
Ella
Vishwas,
retractor,
this scissor works really well.
Sir?
Is it really helpful to have a pointed end? What do you call this scissors? Or even
Walters angled scissors, sir.
Walters angle scissors?
Now what I'm doing, I'm putting the skin hook under the intermediate crura on the opposite side, and then again running my sharp pointed scissors. It is slightly slippery to get into the subperichondrial plane.
the
Once I'm
Ella
into this,
retractor is the Millennium Ella retractor, Vishwas.
sir.
Ella retractor is the Millennium Ella retractor.
Yes, sir. Yes, sir.
Okay.
So now you can see saline irrigation, please. So can you see the lateral crura now? I'm just trying to expose it now. And using that reflection, again, I cut at the points and go and expose the lateral wing of it. Okay. So now it seems like one side I've exposed more, the other side I have to expose equally. So I spread my scissors adequately. Now what you're seeing, sir, I want you to observe this. This is called as the superficial ligament of Pitangai. And what is deeper down is the deep ligament of Pitangai. These are the ligaments which make sure the supra tip is well defined and the tip is well defined. So now there is a concept called as preservation rhinoplasty, where they preserve these and then operate only on the tip and come out. But of course, since septum is our concern, we are not going to be handling that at this point. So what we do first, this is the superficial ligament of Pitangai. Cautery, please. So many people, they take a suture here and keep it retained. For the reason for exposure, I need to expose all these things. This is the deep one. And this is the vestigial remnant of the muscle which is there in our bigger mammals like the elephants, which actually move their trunks above and down. So likewise, they also help us define our tips. So you can see that I'm tunneling and then cauterizing closer to the cartilage and then cutting. Now another layer is there attaching the skin to the subcutaneous tissue. Now my lower lateral cartilages are exposed. You can be seen. Another skin hook, please. So we need to ask our assistants to place the skin hooks like this and keep it wide open. Get the peanuts, please. Cautery sister, don't turn that side. Yeah. Just concentrate. Yeah. Thank you. So it seems that there is one layer here still which is remaining, which I can get into. Can you see that? That is the exact subperichondrial plane. For us, the dissection should be subperichondrial and supraperiosteal. There's one more layer there. Now, next step, what I do for exposure is take a peanut and use the peanut for a soft dissection instead of using the scissors. The advantage of using the peanut for a soft dissection is, get me the lid retractor, please. It helps define the soft tissues, that is the upper lateral cartilage, very easily without having to tear into tissues or cause more bleeding. Peanut should be good without loose threads, okay? Shashidhar sir, Srinivas sir, can you see this? The
Yes,
upper
yes.
lateral
Yeah, we
ascending.
can see it.
Yeah.
We can see it.
Yeah, it's a nice way of dissection without much trauma to the tissue.
Yeah, sir. So once this is done, I should be now going on to the K area. So there'll be a central blood vessel there usually, which we can cauterize or push it to the side.
All right.
So that blood vessel is the one which gets injured usually during trauma and causes edema and hematoma on the nasal dorsum. Now, I haven't still gotten to the upper lateral cartilage area, so I'm trying to still push out. Get me another peanut, please. So now I think you can see the cartilage there. Is it seen, sir? Or should I improve the
Yes.
focus of the camera?
We can see it, but
We
for the
can see it.
benefit of others, can you point it with some instruments, the upper lateral and lower lateral cartilage?
Can you see, sir? This is the upper
Yes.
lateral cartilage now.
Okay,
What you're seeing inside, this is the lower lateral cartilage.
great.
Okay, sir. So
And above the upper lateral cartilage is the bone, nasal bone.
yes, sir. I'll be going this. Angled scissors, please. So there is a tunnel there which I can get into and enlarge it a little bit for us to move inside. So at this stage, what I do is get the Haworth, brother. Haworth elevator, the big one. Haworth elevator, just like the SMR elevator, the big SMR elevator. So now the purpose is to stay 2 millimeter above the bony cartilage junction. So I feel for it with this instrument at the bony cartilage junction, then go 2 millimeters above, sit on the bone, then scratch the periosteum to get into the subperiosteal plane.
So this is better done with a over retractor. That's what you're saying?
Yes, sir, Howarth elevator. So what
Elevator.
I'm doing is I am scratching on the periosteum to get into that plane. It's quite stiff there, but maybe because of old fractures. But then we need to be able to make a tunnel. I hope it is seen on the camera there.
Yes, we can appreciate that.
Yeah, we go up to the radix, just enough tunnel to create a tight tunnel if you're doing an augmentation. Then I go on the opposite side, suction please. Now, once the tunnel is made on the opposite side, same way, we're going 2 millimeters above the bony cartilage junction. And then another tunnel is created. So now one tunnel this side, one tunnel that side. Usually the attachment of the periosteum is into the suture line in the center. So we need to connect these two by doing blunt cuts with our instruments. The reason for blunt cuts is that will help in coagulation and the bleeding to stop. You can also use foam on scissors. Foam on scissors, please. Off-Ritz retractor, please.
Vishwas,
Off-Ritz retractor, sir.
in the event, see, this is a post-traumatic case.
Yes, sir.
In the event that you have an inadvertent buttonholing of the skin on the dorsum,
Yes, sir.
what would be the line of action?
Sir, can you repeat the question, sir? I was just
Post-traumatic
Yes, sir.
adhesions,
Yes, sir.
inadvertent buttonholing on the dorsum.
Okay. Okay. Sir, I would not worry too much. I will first do the osteotomy work and then close the buttonhole when I am closing the whole rhinoplasty. The reason because, sir, when we do percutaneous osteotomy, anyway, we will be making a cut on the dorsum and the lateral side wall.
On the lateral aspect.
Yes, sir. So it's not much of a worry.
Oh.
So now I've connected the two tunnels and then you can see that the scissors are there. Can you see, sir?
Yes.
I hope it is seen.
Yeah, it's clearly visible.
Yes, sir.
Yeah.
I've gone up just up to the radix, not too high, because here we are not thinking of any augmentation. We are only thinking about osteotomy. So leaving that now, I've done the part of the exposure. Now I'll go and expose the septum. Cartilage holding forceps, leave the skin hooks down there. Keep the lid retractor in your hands. So I use the skin hooks to retain. No assistant is holding this. What I keep, you give please. Scissors. Lid retractor. Yeah. Hold. Sir, is the brightness better now?
Kind of, but
it could be better, sir.
Yeah, could be better. Yeah, definitely could be better.
We have increased the light source to 80% and my light is on high intensity. I think it's to do with the camera settings. I'll just try and see how I can.
It's fine. It's fine. The structures are quite visible. I mean,
but we can actually see everything, and whatever you're saying
Yeah.
is clearly demonstrable here. So
Yes, sir. So as I'm cutting in between the medial crura, what I have to notice is the edge of the cordum that is on the left side. So I have to make sure that I slowly move towards the left side to be able to expose the caudal edge. Now, the window for us is the anterior septal angle window, wherein we attack the septum. Normally, if we are doing it in a conventional septoplasty, we would obviously go through the transfixation incision. Now, the reason I'm exposing this is possibly there is a deviation at the lower point as well, because of which the septum is shifted to one side. Okay, so through this, I am trying to feel where the septum is, and just retract the skin hooks like this. Yeah, thank you. And I'm holding it and going small snips only until I find the anterior septal angle. Please keep mopping. Thank you. So now I go spreading way. I don't try to cut after I made the initial cuts, just to try and find where my caudal and dorsal edge could be meeting. Mop, please. Sir. Sir. Yes, sir. Okay, okay, sir. Sure, sir. Sure, sir. Yes, sir. Yes, sir. Yes, sir. Thank you, sir. Mop, please. So then you cut the medial crural, intercrural ligaments. These are the intercrural ligaments which hold the medial crura together. And once you are cutting that, you need to make sure that you're going to put it back again. Because if you don't put it back again, then the patient will have a wide columella and possibly an unsupported tip which keeps falling down. Okay, Mop, please.
Whatever dissection you do here, Dr. Vishwas, is going to help you create space for a spreadograft. Is that what?
No, sir. I'm going to go near the
later
septum
helps?
right now. I'm trying to find the
Septum,
anterior
yeah.
septal angle. And once I find the anterior septal angle, I should be able to address the whole septum from there.
Raise the whole flap from outside.
Yes, sir. So what has happened is it is turned inward. Suction there, please. It is turned here and gone to the opposite side. So it is likely that we get confused by the actual caudal edge. That's why I'm going a little slow to see the caudal edge and then only be able to elevate it. The caudal edge seems to be here. So what I'll do is I'll ask my assistant to take an instrument, possibly a peanut-laden artery.
And something to mobilize it so that it's in the midline.
Yes, sir. Something to push it like this. Somebody hold it like this, please. Hold it there. Yeah. Because it's very easy to get into a different plane altogether. So keep it there. Keep the position there, Arjun. Push it, pull it down. Yeah. So the reason we need to attack from the anterior septal angle is that gives us a panoramic view or a vantage point to handle both the dorsal part of the septum and the caudal part of the septum. I can easily enter at this point, but then I'll have to be digging into a blind tunnel. So once you find the anterior septal angle, it would be easier for us to go and address the septum. I think I'm almost near the anterior septal angle. What I'm doing right now is not cutting too high because I don't know where the upper laterals start. So I hope you can see, sir, part of the reflection of the anterior septal angle.
Do you have a feeling that
Yes,
the
yes, that
So this would be the safest entry point because you do not have, Mop, please. You do not have any
can the
ligaments.
camera zoom like another 20% so that
Yes,
we
sir.
actually see that? Can the camera zoom another 20 to 30%?
Definitely, sir. Definitely. Arun, please. We have the stores people who have kindly agreed to stand by and help us with their 4K cameras. This obviously is not the 4K camera. The 4K camera will be coming into the play in the endoscopic sinus surgery and the endoscopic work. This is a Striker 1488 that we are using to transmit, but we have a VTOM here thanks to the contribution from the stores people. Now the skin hooks away, please. Yeah, leave that. Take it out.
do you have a feeling that the there is crumpling and pushing it away from the maxillary crest?
Yes, sir. It looks like, sir.
Yeah.
Looks like it is away from the maxillary crest.
Yeah.
And there is a lot of fracture lines over there.
Yeah. So something like the Jardive and Chevalier fracture type where the septum is.
Yes, sir. Can you see it's gone in totally?
Yeah.
Sir, is it too bright and shiny? I am not able to see it on the screen properly here. I can see it clearly in my loop and all, but is it too
No,
bright out there?
I think you should go on, continue. We can appreciate, fair enough.
More, please.
Vishwas,
Yes, sir.
there's a little more reflection of the light. So I think maybe you should reduce the intensity of the light a little bit.
Yes, sir.
Yeah. The light is getting reflected from the your wonderful stainless steel instruments.
Oh, I'm so sorry.
No. That's actually a compliment.
Arun, can you just look at the illumination also, please? You have
Yeah,
adjusted?
this is fine, Vishwas.
Yes, sir.
Yeah.
Scissors, angled scissors, please. So there is a deviation of the septum down there also. So it is a good practice to actually understand the cartilage and the bone before we go in. But many times there are few surprises when we get in. Take another glass, please. Give us a line wash.
Very well dissected, Dr. Vishwas. Now we can actually see the whole dorsal part and the columnar part of the septum, most of it.
Gauze piece. After wash, gauze piece. So there's a lot of fractures at the tip. So I'm going a little slow just to find the actual caudal edge of the septum. I'm releasing all those adhesions. Hold this. Give it. A lot of adhesions with the fracture that is tightly bound, and that
Yeah.
is what is restricting our movement.
At this point of time, I think we should take a little, a few seconds away to go back into history to think about all those people who did those procedures, Galloway's procedure, Pierce procedure, Metzenbaum's procedure, then morselization.
Yes, sir. I think at that point of time, as the science evolved, please.
Yes. Of
Arjun,
course,
just
we need
pull
to
up.
remember Cottrell's maxilla, premaxilla approach too.
Suction inside, please. So lot of adhesions there. You can see my sharp scissors are also not able to maneuver that edge. Okay, out. So once I'm into an adequate plane, I'll skip to the SMR elevator.
Some time ago, we attended a similar live workshop
Yes, sir.
when Wolfgang Gubisch had come to Goa.
Yes,
So
sir.
when you're doing this, I remember he used to take out the entire septal cartilage, make burr holes, remove the elastic bands, and then reinsert the cartilage, the famous Gubisch technique.
Yes, sir. The extracorporeal septoplasty.
Yes.
If I find that the deviation is too much, sir, I might also have to resort to that technique here.
Right.
So now what I'll do, since I've exposed the anterior septal angle, I'll try and reach a little higher and see where the cartilage is attached. Cutting scissors, please. Because it looks like the cartilage is fractured in the entire
Sort of more crumpled, like a
Yes,
parched
sir.
paper. Yeah.
Yes. Okay. Get me the first size speculum, please. Leave it, leave it, leave it, leave it, both of you. Take out. So I'm just trying to ascertain where I am possibly seeing the caudal edge and where it is actually so I'm trying to go at the convex edge.
Are you on the nasal spine, Vishwas?
Which is turning towards the opposite side. Suction, please. Suction. I need this to be cut and attached only to this. Okay. Regular suction, please. Sir, give me a second. I'll just get the suction in working. The cartilage is quite fragile. So I'm slowly elevating the cartilage. Second size, please. Get me the sharp scissors. Okay. Suction inside. Suction inside. Just suction, hold it there. Out. Suction. Take the other suction. Yeah, that's okay. That's okay. Suction. So I've gone beyond the fracture line now. Just trying to retain the So I think it's visible now, the fracture line here. Hello,
Yes.
can you see, sir? It's
Yes.
lying
Yes.
horizontal.
Yeah.
Lying horizontal rather than. So that edge had gone like this.
Yeah.
And now, because of the release of the stressors, now it is tilting to the opposite side because the stressors are this side. So
Yeah.
I'll try to release the septum from this side now. I've gone beyond the fracture line here. So to progress further, I will need to see what has happened on this side of the septum.
Yes.
Cartilage holding forceps, please. Arjun, you're supposed to hold it in the center for everybody to appreciate, not to one side. Gauze piece, please. So what I'm doing now is utilizing the sharp scissor itself to get into that right plane. Suction there, please. Here.
Probably you would have had a little bit of septal hematoma and little organization.
Yes, sir.
And then
Looks like.
recovered. Yeah. And then recovered. Otherwise, this kind of buckling of the cartilage is not seen generally.
Yes, sir. It's fractured at various places. So can you put something here, some instrument here? Yeah. So now, since I've gone up till here, to improve my exposure, I will go and put my scissors or rather dissector way up to the upper lateral cartilage and the septum envelope here. I'll go all the way up to the K area by dissecting off here. Same thing I will try to do on the opposite side. Suction, please. Arjun. Suction here, please. Thank you. Suction, please. Here. Thank you. Sharp scissors, cutting scissors. Cutting angle scissors, please. So there are bands of tissues holding the septum to the perichondrium. So I'm cutting it sharply. Suction. Suction. Suction.
So Dr. Vishwas, if the cartilages are fractured very badly,
Yes, sir.
what is the contingency plan? Sometimes they literally tear off and you may get a piece
Section.
outside. Then
Yes, sir. So
how do you proceed in those cases?
most of the time, sir, it's the anterior part which is most deviated and fractured badly. Suction, please. So what I'll do is I'll make sure I retain the perpendicular plate of ethmoid so that I can batten the cartilage with that. If I'm not getting a straight piece, if I'm not getting a straight, yeah, scissors, scissors. Sir, your voice is not heard clearly, sir. Shashidhar, sir.
I'm still in the audience, sir. So what is it? Cartilage you're separating right now with the upper lateral cartilage or from the
Yes, sir.
keystone
This is
area of the system?
this is the upper lateral cartilage. I've
The
not yet
cartilage.
gone to the keystone area. I'm going up there, but you can see that how
Okay.
badly the septum has been
Hmm.
fractured. So going slowly and releasing it.
Absolutely. Yes. Yeah.
Okay. SMR elevator, sharp SMR elevator.
Most of us will give up at this point of time.
Suction. Get the other suction ready, please. So I want to separate the upper laterals properly and then proceed on to doing the septal work suction inside. Here, suction there. Here, here, here. It looks like there are adhesions between the lower part of the septum and the upper laterals also, which you can see me separating right now, sir. Sharp scissors. Suction, please. Umesh, brother. Suction properly. Suction here where I'm. Thank you. Thank you. So you can see that adhesions between the upper lateral and the septal assembly, and that has to be released unless I want to just do the
Absolutely.
septal. So now I'll put the speculum and see, second size speculum. Don't suction. Suction, please. Sir, is the camera able to focus on what we are doing?
Yes, quite clear.
You can see this adhesion.
We can see a little bit, but endoscope would be much better at this.
Yes, sir. So the purpose of
But do we have an endoscope there? So
sir, we want.
just for the visualization.
Yes, sir. I'll just do the exposure and try to put an endoscope if possible.
Great.
Sharp scissors, please. Suction the way I did it now. Suction. Here. Out. Suction. Suction. Yes, sir. Suction. Yes, sir. Yes, sir. Yes, sir. Yes, sir. ಹೌದು sir. And too much of adhesion, sir. Yes, sir. Yes, sir. Suction. Arjun. And I do the surgery. You should assist the surgeon, not come in the way of the surgeon. Okay. Suction from the side. Suction. 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 Inside. Inside. Suction. Inside where the reflection is there. Yeah. Thank you.
So now you're separating the lower part of the septum?
Yes,
With
sir.
the crest?
Getting into the cartilage. Now posterior part, again there are some deflections.
Oh God. So do you create tunnels here like what we do in endoscopic septoplasty or conventional septoplasty, or there's no need for tunnel?
Same technique, sir. What I do is I go above and below, then connect the two, because we need that entire piece to be visible to us, because I need to see the whole septum in its complete vertical stance.
Entirety.
Yes, sir. So this is that attachment, concave attachment you can see. Sir, can you see that?
We can see it. We can see it, but like I said, first you free it all and then show us it with endoscope, then everybody would appreciate what the work has been done. Yeah, now we can see it actually, yes.
I had to hold my instrument like
That's
that, sir.
a bad deviation there. Yeah.
Hold like this. Just hold, okay? Okay, it's okay. Out, out.
Is it a bony spur there or it's still cartilaginous? Sorry.
So it's a concave part. It's a concave part which I am elevating right now. So I'm using a sharp SMR elevator and using pushing motions.
Right. Okay. So we have two elevators. One is a Friels and other is a Cottels. Which one do you prefer and why?
Sir, the sharp elevator, especially near the fracture lines, because we need sharp
Near the
cuts.
fracture line.
Some of them use knife. I prefer this sharp elevator. You can see that there is one more fracture line here. Can you see, sir?
Yes, sir.
Can you see there is one more fracture line here?
Now
This is
Yeah,
concave
it's
here.
visible.
Again, another fracture line here. So here I would prefer again my sharp elevator to go beyond that edge. So what I do, I try to push my third size speculum, please. Suction. So literally it's an S-shaped deviation in the horizontal and vertical planes, sir, along with some adhesions and anterior fragile cartilage. As C.V. Srinivasa mentioned, possibly a septal hematoma and an organized scar, which resulted in this whole process.
It's very important for younger colleagues to understand that when we say deviation, we have to say both in horizontal and vertical axis. The C-shaped and the S-shaped, generally we take it in the vertical plane and then forget about in the horizontal plane. So, because that can actually have a lot of impact on the type of surgery you're intending to do.
Yes, sir. So right now on the cartilage, I'm trying to go slow and release that inferior tunnel. Suction.
Vishwas,
Sir?
can you ask the person who is focusing on the operating field to come a little towards the left, not able to see what is being dissected?
Sir, is it better now, sir? Trying to hold the speculum towards the...
He needs to move. I think the camera needs to move
The camera needs to come at your head level, so it's slightly difficult, challenging way to do it. I think. Or we can wait for a minute or two. Could you release it?
Fine, fine. It's fine.
So sharp scissors. Keep the suction ready. Third side. So on one side, my flaps are intact. So can you see inside?
It is a bit dark.
This is one fracture line here at the bony cartilage junction. Can you see the bony cartilage junction, sir? That's the bony cartilage junction there. It's quite deep. So what I'll do is I will separate the upper laterals and try to show you, sir. Get the saline wash, please. Yeah, that's fine. SMR elevator. So can you see it or it's in alignment? Yeah. The camera is turned, Arun. That's the reason it is out of. You need to give them proper alignment. Can you fix it?
Now
there?
this is better. Yeah, this is better.
Yeah. Now here the camera had turned. I am just adjusting the camera, sir. Just hold on with me.
Vishwas?
Yes, sir.
What certain things have come in online. So,
yes, sir.
If okay with you, I'll briefly put you on certain aspects. We have a good appreciation from Dr. Renbontung Lota, very clear picture demonstration. And Dr. Lakshmi has told that very good start, nice flap elevation, looks like a traumatic case, lots of fractures, excellent work.
Thank you, sir.
Yeah, they are the kudos for you. And some questions can I take at this moment as you're operating?
Definitely, sir.
Yeah. One is, sir, is it suction elevator from Dr. Smita Chandra? What is the name of the instrument?
Leave it. Leave it. It's okay. It's okay. It's coming there. Huh? Focus. Huh? Suction elevator from stores company I'm using, sir.
Yeah. Yeah. Even I'm not aware of the name of the instrument. We just know it as a suction elevator. If you have anything more to highlight that, yes. Otherwise, we skip that.
No, sir. I don't know the name of that.
Yeah.
So now what I'm doing is, especially in this type of deviated septums,
Yeah.
I go face down, looking into that angle between the upper lateral and the septum. Actually, I don't think you're seeing. I go down like that
Yeah.
into that angle, try to separate because the upper lateral would have also twisted. Sharp SMR, please. So since there are deviations in many planes, we need to get into the absolute plane where the upper laterals get reflected from the septum and adequately dissect out and release that area. Because unless we release all the stresses, we won't be able to correct the septum.
Another question from Dr. Vinay Wainard.
Yes, sir.
Can we watch this offline on YouTube later?
Yes, I'm sure you can, sir.
Okay. A question I think addressed to you as well as the anesthetist. With 4% lignocaine and adrenaline, is it safe on a raw bleeding area while doing FES or any other procedure like what we are
Sharp
doing
scissors.
now? Can 4% lignocaine go intravascular?
4% we are not injecting, sir. So we're using 2%.
Topical.
Going intravascular, no, I doubt it. Our anesthetist might be better in answering that, sir. They might have seen.
Topical absorption does occur, but not to an extent to the level of causing a toxicity.
Yes, sir.
Yeah, if there is an abrasion on the mucous membrane, absorption is a little more. So other than that, I don't see any major issues with topical absorption.
The way the cartilage is bent in all directions, sir, looks like I'll have to take it out and redesign it and place it back.
Yeah.
Nevertheless, I'll complete the exposure of the septum and then give you an update on what can be done, sir.
Yeah. Invariably, for all demonstrable cases, I think we'll end up with real tough ones.
Clean all these things. Clean on the side. Yeah. So apart from a deviation, there's a spur also. So is this part seen, sir, or?
Not very clearly, but I know your difficulty because it's a fixed camera which cannot be moved. Only that you have to move it a little here and there. As long as you're comfortable, please go ahead.
A lot of adhesions at the fracture line.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you very much. Thank you. Thank you, sir.
Suction. Yeah, SMR elevator. Section, please. So I have exposed the septum with the spur. Huh? 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 Matsi. Yes, sir. Yes, sir. Sure, sir. Sir, I would just want to show you the deviation spur there.
Yeah, it's visible.
This is the cartilage spur there.
Yeah.
And the septum is here.
Okay.
The cartilage. So anyway, I've exposed till the bone posteriorly. So inferior tunnel on the right side is yet pending yet. So I'll just do that and then the septal release will be complete, sir.
Okay.
So what I did was I went on the concave side first because there was a sharp spur on the right side to retain the flaps so that at least one side the flap is intact. So once the flap is intact on one side, what happens is you're sure that the perforation would not happen. Only when you have opposing edges, the perforation would happen. So now the place where I'm operating, the bone and the cartilage is deviated. So I think now you can see the septum in its entirety, sir.
Yes, very clear.
There are more deviations behind.
Yeah.
So this was the caudal edge lying there. There is a fracture line here.
Yeah.
There is a fracture line here going
Yeah.
down. And there are few fracture lines inside as well. Can you see this, sir?
Yes.
Okay.
Yeah.
And just a minute. Don't bring your hand. You should come around like this. Yes. Inside also there are some fracture lines. This is one fracture line, sir. I hope you can see this.
Yes.
Can you see it, sir? This is one
Yeah,
fracture
true.
line deep
Yeah,
inside
yeah.
at the bony cartilage junction.
Yeah.
On this side, this is one major fracture line here. So the cartilage is folding on itself and going there.
Yeah.
So I wouldn't have imagined doing this either
Thank you, Vishwa, sir.
endoscopically or conventionally. So just few things I want to mention before I start exposing the septum, sir. Now, when we are doing this, we need to address the septum in 5 areas. Now, one is the caudal edge, something deflected like this to one side. We need to get it to the center and take a stitch.
Yeah.
And something with a fracture line like this, we need to batten it with a cartilage graft and straighten it.
Yeah.
Because this whole caudal edge is not supported.
Yeah.
If you go to the spine, if the septum is off the spine, we need to get the, like in this case, you can see that the septum is here. Can you
Yeah.
see, sir?
Yeah.
I'll just show the spine area. Can you see, sir?
You need to anchor it to the spine.
Yes, sir. Can you see that it's gone to one side, sir? Can you see that?
Yeah.
Yeah. So that I need to get it to the center. If
Right.
the spine is projected to one side, I need to break it on one side and then place the septum on the center.
Yeah.
That is one thing that we do for the spine. Going on to the dorsal edge.
The dorsal strut also should be fixed, I guess.
Yes, sir. The K area is also deviated. So it will require osteotomies for me to align this, along with a straight piece of cartilage kept as a extended spreader graft, which is going to straighten the cartilage.
Yeah.
Now, going on to the central area of the septum, whatever the deviation that has to be removed. If the bone is also deviated, that also has to be removed. Very rarely deep inside we put a batten. Only when the septum is so curved and we do not have much septum left, we go for putting a batten graft in the center of the septum. So these 5 areas we need to handle separately. Only when we handle these 5 areas separately, we are likely to get a complete result rather than handling only one area for the breathing issues. Now, if there are problems in more than 3 areas, like let's say the caudal edge, the dorsal edge, the spine, and these 3 areas or any other 3 areas which I mentioned, then it is better to remove the whole septum, align it correctly, design it correctly, and then place it back.
Vishwas,
Sir?
I think we are on to the next case in the other OT.
Yes, sir.
And probably I think some inauguration. There's a talk. There's a talk in the auditorium.
Yes, sir.
So your surgery will continue.
Yes, sir.
And if you permit me, I will log out, and the other moderators will be there, and things will move on.
Yes, sir.
And thank you so much. It was such a pleasure. And
Excellent demonstration.
hopefully we'll come back to you and meet you sometime.
Yes, sir. Thank you.
Thank
I
you
will
so
so much,
continue
Dr.
on.
Vishwas.
I'll continue on PIP, sir.
Yeah, you will be on PIP.
Yeah. Thank you so much, Dr. Shashidhar and CV Srinivas, sir, for
Thank you, sir.
moderating the show today, sir.
It's been our pleasure and lovely demonstration. Thank you so much.
Thank you, sir.
Thank you, Vishwas sir. Thank you, Shashidhar sir. Thank you, Srinivas sir. We can move on to the
Tomorrow elevator.
next session. I would like to call upon Dr. Ashish Rao
I mean,
from Department of ENT, Assistant Professor, to talk about few words on role of inferior turbinate surgery in allergic rhinitis patient.
Hold. Sir.
Thank you. Good morning.
Slideshow, sir. Make a slideshow.
So my topic for today is the role of inferior turbinate surgeries in allergic rhinitis
mic off?
patients. So a brief introduction. Allergic rhinitis is a chronic immune mediated inflammatory condition of the nasal cavity, which has the hallmark symptoms of sneezing, nasal obstruction, and watery nasal discharge with anosmia in severe advanced cases. A plethora of intervention is at our hands as an otorhinolaryngologist and in relieving the symptoms of allergic rhinitis.
Okay.
However, the literature yet to determine which is the best modality
lot
of
of
treatment
difference.
for our allergic rhinitis patients. Yeah. Turbinate hypertrophy is observed in various conditions, including allergic rhinitis, vasomotor rhinitis, and
Yes, sir.
infectious rhinitis. And
हाँ आराम
treatment.
से हाँ हाँ बिल्कुल बढ़िया ना राइट राइट
So sorry for the interruption. So turbinate hypertrophy is observed in various conditions such as allergic rhinitis, vasomotor rhinitis, and infectious rhinitis. In the treatment include both non-pharmacological, that is environmental control, or with the treatment that is based on antihistaminic, decongestant, topical, and systemic steroids, and other treatments such as ipratropium bromide, chromoglycate disodium, and anti-leukotrienes. Immunotherapy is a very good way of tackling the allergic rhinitis in a long-term basis, and use of saline nasal solutions for nasal irrigation or other choices which are available. So modern techniques offer a better and good option for treating clinically allergic rhinitis patients. So the role of inferior turbinate in allergy. So the mucosa lining the inferior turbinate at the first point of contact for the inhalant allergens, making them the prime site of allergic inflammation and nasal obstruction. So the inferior turbinate surgery increases the cross-sectional area for the nasal valve, relieving the sensation of nasal block, that is increasing the amount of air taken into the nasal cavity. In addition, reduces the net mucosal surface area, which limits the attachment of potential allergens. So as we all know, the inferior turbinate is a bony and which is connected to the palate and the ethmoid and the lacrimal sac. It contains that is the three layers, that is the outer mucosal layer, which is rich in blood supply, soft erectile tissue beneath, and the bone in the center. The characteristic feature of the inferior turbinate is it can expand according to the situation. So with the use of this erectile tissue, so whenever there is any expansion of the inferior turbinate, there is a significant increase in the surface area, making it more prone for allergies. This surgical technique can target mucosal covering, the submucosal layer, and the bony center, or infrequently all three parts. Submucosal resection with the microdebrider or a bony resection widely used along with cautery, laser, and coblation in controlling the allergic rhinitis. So basically, we are reducing the surface area so that the amount of allergens which are getting attached to the nasal mucosa is reduced. Surgical treatment for allergic rhinitis refractory to the clinical treatment is directed towards the inferior turbinate, which aims to increase the nasal cavity without altering the physiology or physiological function. The surgical procedure that aims to reduce the mucosal or bony hypertrophy of the inferior nasal turbinate or both include steroid infiltration, lateralization and dislocation of the inferior turbinate, partial turbinectomy, lower turbinoplasty, cryosurgeries, laser evaporation, and radiofrequency ablation. The turbinoplasty is a procedure aimed to reduce the size of the inferior turbinate and removal of bone and the meatal surface, removal of greater mucosa, and have a greater mucosal preservation. It allows to reduce the turbinate volume while maintaining the physiological function of the mucosa. There are several studies in the literature that assess the improvement in the nasal obstruction after the inferior turbinate operation. So coming to the surgical procedure of the inferior turbinate involves removal of the mucosa, erectile tissue, the soft erectile tissue, and the turbinate bone. So it is widely divided into two types, that is non-mucosal preserving surgery and mucosal preserving surgery. The field of interest for us to treat the allergic rhinitis patient is mucosal preservation surgery. Why? Because non-mucosal preserving surgeries such as conventional turbinectomy, electrocautery turbinectomy, laser turbinectomy, and cryoturbinectomy is a extensive surgery wherein we remove most of the turbinate and we have no surface area there. Whereas mucosal preserving surgeries help in preserving the normal nasal physiology and prevent such complications such as excessive bleeding, excessive crust formation, synechiae formation, or even to some extent atrophic rhinitis formation. Mucosa preservation also helps in increasing the surface area, increasing the mucociliary clearance also, which we require. So there are indications for turbinate surgeries and the grading system. Nasal obstruction occurs as a result of submucosal or mucosal hypertrophy associated with increased vascularity of the inferior turbinate. The treatment of the inferior turbinate hypertrophy consists of topical intranasal corticosteroid spray, oral antihistaminic, and topical decongestant. When the conservative management fails within the appropriate treatment period, the surgical treatment is indicated. Generally, the consensus for the point of surgical intervention is at around 3 months, ensuring the failure of the medical treatment to resolve nasal obstruction as a result of turbinate hypertrophy. On your right-hand corner, there is the picture depicting the grading system of the turbinate hypertrophy. So it is being divided into A, B, C, D, or grade 1, 2, 3, 4. So grade 1, which means that the inferior turbinate is occupying 0 to 25% of the total airway space, which is available in the nasal valve area. There are different grading systems. So this four grade system is clinically one of the most appropriate for our cases. So This grading system is given by Cameo et al. So the 4 grading system is grade 1 0 to 25, grade 2 26 to 50%, grade 3 50 to 75%, and grade 4, that is 75 to complete nasal obstruction. There are other way of classifying the turbinates as well. There is three staging process, that is mild, moderate, severe, and there is one Uzan's classification, in which it is based on CT scan. There are 4 types. Type 1, which is lamellar; type 2, which is compact bone; type 3 is combined; and type 4, bullous. So coming to the turbinoplasty, the conventional turbinoplasty. So turbinoplasty involves removal of all or a portion of the inferior turbinate and may be performed by direct visualization with the aid of endoscope. The degree of excision can be anywhere from limited to complete resection depending on the degree of hypertrophy, and include turbinate mucosa and soft erectile tissue or bone. This surgery is designed to remove the non-functioning obstructive part of the turbinate while preserving the functional medial mucosa, which plays the key role in the warming and humidification of air through the nasal passage. The second type is the microdebrider turbinoplasty, wherein we use the microdebrider. Microdebrider has become widely accepted as a useful tool for the sinus surgery, with the capability of continuously suctioning the blood from the operative side, allowing a better surgical vision or field vision, permitting precise tissue removal of the mucosal sparing manner. So using the microdebrider, the whole lateral aspect of the inferior turbinate mucosa and soft electral tissue is removed in an anterior to posterior direction. A comparative study conducted by Chingi et al. Was assessed to assess the microdebrider turbinoplasty with that of the radiofrequency ablation turbinoplasty. The patients were assigned, 2 groups were done, and the symptoms were statistically significant in microdebrider group on the 1st and 3rd month of surgery. Next is the coblation turbinoplasty. Coblation is a unique method of delivering radiofrequency energy to the soft tissue for application of surgery. By using radiofrequency as a bipolar mode with the conductive solution, that is saline, its energies energize the ions in the saline to form a small plasma field. The decreased thermal effect consequently lead to less pain and faster recovery of the cases where the tissue has been excised. The coblation includes reduction of inferior turbinate by vaporization and destroying the soft erectile tissue, and the volume reduction and the soft tissue fibrosis are immediate and sustainable. Further, the swelling and hypertrophy of inferior turbinate are prevented by contracture and anchoring the mucosa to the periosteum as a result of fibrosis. So what is the surgical impact on allergic rhinitis? So the outcome of the surgery is based on 2 things. The first one is the symptomatic and the functional outcome following the allergic rhinitis surgery, and the patient's quality of life following the surgery. So to answer this, assume that a study was conducted in Brazil, where in outcome of turbinate surgery in non-allergic and allergic patients, comparing all 3 surgeries, wherein there was significant improvement in the patient's breathing, as seen in the chart, in the first 7th day of post-op, first day, and the first month, 30th day, and the 90th day. So there was significant increase in breathing patterns. And as well as the improvement in olfaction was significant, and relief in allergic symptoms as well, that is sneezing and rhinorrhea. Allergic rhinitis refractory to the medical therapy can be challenging, and inferior turbinate hypertrophy has been suggested as a major cause of nasal obstruction in various patients with allergic rhinitis. In addition to that, our another challenge is the nasal septum deviation and the chronic rhinosinusitis, which goes hand in hand in allergic rhinitis patients, possibly causes more worsening of symptoms. Various procedures exist for surgical reduction of inferior turbinate volume, which we have discussed, and have a good impact on post-operative period for the patients and allergic rhinitis. Recent years, the conservative turbinate surgery has been widely applied to decrease the complication such as empty nose syndrome, crust formation, osteitis, Seineke formation. In some cases, septoplasty would be important mode of treatment along with inferior turbinate surgery to treat the allergic rhinitis. with coexisting nasal septum deviation. Because surgical management of allergic rhinitis may cause some troublesome complication, so the invasive procedure should be chosen carefully. So in conclusion, early intervention and combined approach gives the best results. A combination of surgery, that is turbinate reduction, and if deviated nasal septum septoplasty with post-operative nasal spray, and for a long-term basis, immunotherapy can give the best results for moderate and severe cases. Mild cases can be effectively managed by medical line of management, that is the sprays, and patient selection for surgery is of utmost importance for the success of the treatment of allergic rhinitis. Use of modern techniques such as microdebrider coagulation are very beneficial in terms of post-operative complications and post-operative recovery time. Thank you.
Explain, madam.
Sir.
ಅದಾದ್ಮೇಲೆ ಅವರು next case discussion
Sure, sir.
You take
Hello.
5 minutes now. Audio shift.
Cartilage holding forceps, please.
Thank you, Dr. Ashish.
Hello.
Now I would like to thank all the HODs from our live centers for joining us, namely Dr.
Hello.
Soumya Dipta De from Tarjan National Center, ENT in Kolkata, Dr. Girija Gate, DY Patil Medical College, Pimpri, Pune, Dr. Viral Prajapti from SMS Multi-Speciality Hospital in Gujarat, Dr. Ravindra Gadak, KIMS Hubli, Dr. Ashok Kumar, RML Hospital, Delhi, Dr. Yogesh Doplakar, DY Patil Medical College, Nellore, Mumbai, Dr. Renuka Bardu, LTGM Hospital, Sion, Mumbai, Dr. KK Samtre, KIMS, Orissa, Dr. Sushil Gaur, Santosh Hospital, Ghaziabad, Dr. Neena Chaudhary, Safdarjung Hospital, Delhi, Dr. Jagannath, KIMS, Bangalore, Dr. Chandra Kiran, MS Ramaya, Bangalore, Dr. Anupama Mishra, KJMU, Lucknow, and Dr. SV Ramna, KIMS, Hyderabad.
Manoj.
Now moving on to the
Yes,
second session of today, endoscopic septoplasty with functional endoscopic sinus surgery. Introducing the moderators for this session is Dr. P. Harihara Murthy, MBBS MS ENT DLO in ENT, graduate from Kasturba Medical College, Bangalore, post-graduation DLO and MS from Bangalore Medical College, has more than 3 decades of experience in otorhinolaryngology, presently associated with Apollo Spectra Hospital and Agadi Hospital apart from his own practice in Kormangla. The second moderator being Dr. Sanjay Agarwal, MBBS DLO ENT, has his graduation and post-graduation from MGM Medical College, Indore, surgical training from Mumbai in 1991, advanced surgical training from Germany, Austria, and Switzerland in 1996 and 2001. Invited as a special guest faculty in Ulstein Symposium 2001 and Wolfsburg, Germany. Delivered talks and demonstrated live ear and sinus surgery at many places, both nationally and internationally. Served as the national president in AOI in 2016 and 17. Scientific chairman Oceania, ORL, HNS Congress and ECON 2019 in Hyderabad. Also national scientific chairman for the ECON 2020 Nagpur. Coming to the third moderator, Dr. Jaiprakash Reddy, MBBS DNB ENT, has 23 years experience as a consultant at the Sri Satya Sai ENT Hospital, Kurnool, Andhra Pradesh. Has conducted over 27 temporal bone dissection and live ear surgeries workshops so far. Has done fellowship in otology with Andre Sultan in Paris. Has also presented many papers, more than 170 at various conferences, conducted many panel discussions, delivered guest lectures, and has a special interest in micro ear surgery for the ear and pediatric bronchoscopy, and has got around 17 gold medals at various levels so far. I would also like to thank Dr. G.C. Ravi, Professor of ENT in Adi Chunchandgiri Medical College. Thank you, sir. Now moving on to the case presentation for the second session, endoscopic septoplasty with functional endoscopic sinus surgery. The functional endoscopic sinus surgery would be performed by Dr. Deepak Haldipur, and then followed by septoplasty, which would be performed by Dr. Naveen Krishnamurthy. Coming to the details of the patient, here's a female patient aged 28 years, presents with allergies, has excessive sneezing on exposure to dust, complained with comes with nasal obstruction around 2 years back with more, which is more on the right side and associated with nasal discharge, that is mucoid inconsistency. Also complaints of headache, throbbing headache in the frontal region. So hence consulted a doctor this year, and then after clinical evaluation got posted for surgery. Now coming to the clinical examination, the external appearance of the nose skin over the nose, dorsum, columella, ala, vestibule, and the tip rising test appear to be normal. Whereas on the anterior rhinoscopy, the nasal septum is deviated to the left side. There's discharge present in both the nasal cavities, bilateral inferior turbinate hypertrophy present, and the cold spatula test revealed reduced fogging bilaterally. There was no improvement on Cottel's test and bilateral reduced movement on Cotton-Wisp test, whereas all factions seem to be normal. Coming to the nasal endoscopic findings, there was anterior deviated nasal septum to the left side, whereas high deviation on the right side with spur. There was discharge present in both the cavities. The bilateral inferior turbinate cobblestone appearance was seen, and there's a pale single polyp present in the left middle meatus. The choana is clear. These are the pictures describing the diagnostic nasal endoscopy. As we can see here, left polyp present in the left cavity, and then this is the spur which is present in the right cavity. Coming to the CT findings, there's involvement of the left maxillary. There's opacification, complete opacification in the left maxillary, whereas there's opacification in the bilateral anterior ethmoidal and partial opacification in the posterior ethmoidal sinuses. The left osteomeatal complex is obstructed, and the sphenoid sinus is well pneumatized. Now I would conclude my presentation and go over to OT. Thank you.
Show me that cartilage, brother. Yes, sir. Sir, just to give a small brief on what I've done, I've released the cartilage. Get me the cartilage forceps, please. Yeah. This was the cartilage, sir. Partial extracorporeal release I have done. This was the deviation that was there. Released at the point and left behind a small portion of the cartilage here. And you can see the various bends of the cartilage, and it's quite fragile. There's hardly any strength to this cartilage piece. So my contingency will be to use the conchal cartilage now. And because this portion is still stiff, I can use it for the dorsal edge, and the caudal edge I'm going to straighten with the conchal cartilage. Inside, I just want to show you, there is still a residual deviation of the bone. If it can be focused inside, can it be seen?
Yes, yes, we can see.
The bone is still deviated, sir. So that bone, I need to again straighten it out. I will be utilizing that bone because once I drill it and make it sieve-like, it can help me batten the tissues. So, show the cartilage. This cartilage here, the zones which we can usually utilize are the central zone and the maxillary crest zone. These are weak zones here. So this is, when you're going to put it back, you can make sure that the attachment is done to the partial portion left behind in the cartilage. And once you get the batten here, this also becomes straight. Now this curved portion, which was lying under the bone of the spine, needs to be removed, and thereby his obstruction will also go away. I think you can shift to the other OT now. Thank you, sir. SMR elevator, please.
Vishwas,
Yes, sir.
I think Deepak is in waiting. Can we have a switchover with your kind permission?
Yes, sir, definitely. I mean, I just wanted to show a little bit of what has been done.
Yeah, yeah.
And then the OT can move to the OT number 1.
Yeah. Thank you, Vishwas.
Thank you, sir.
Yeah. Whenever time permitting and situation permitting, we can always revert back by the time if you haven't finished. So We now will move on to
Cartilage forceps.
the other case. In the other OT, can we have pictures from the other OT, please?
Lux forceps, please.
Hello.
Sahibre, namaskara.
Hello, Sanjay Saab, I can see you on the monitor. Good morning.
Yeah, good morning, Deepak.
Good morning, CV Srinivas.
Good morning,
I
sir.
can call him the singer or Kasturi Nivasa Srinivas also.
Hey, Ilappa.
Yeah, first of all, I would like to thank the management of Rajarajeshwari Medical College, where I am the honorary professor as well.
Third
See,
size.
this particular patient, hi Jai Prakash Reddy.
Good morning, everyone, sir. Nice to see you back in action. And
Kurnool and Indore are connected together along with Bengaluru. So it's so nice to see Sanjay in his clinic.
Deputy sir, good morning.
good morning, good morning.
Dr. Sanjay, good morning, sir.
Let me do my formalities. Number one, this patient came to us with 450 sugar, and also the patient came to us with a hemoglobin of 20, polycythemia, and there were many other problems. I first thank the anesthesia department that took about 15 days to work up this case and made the patient fit for this workshop. In the bargain, it also gave us time to give good antibiotics and steroids for about 15 days. And, because of which the polyps have all regressed nicely, the infection has come down. You can see 2 sinuses have cleared up also. And I'll read the CT scan for you shortly. I would like to thank the management of Rajarajeshwari Medical College and the ENT department of Rajarajeshwari Medical College, headed by Professor T.M. Nagraj, Professor Sriranga Prasad, then all my friends, Dr. Rajiv Sanji, Dr. Girish Hongal, Ashish Rao, then we have our Dinesh Kumar Rajendran, and all of you. So I am really happy to be Dr. Praveen, not to forget Dr. Praveen. I'm really grateful to them for giving me such an excellent setup. I would like to thank Carl Stores because they have brought in the 4K monitor. They have got 2 4K monitors. They have given us the VTOM. The Medtronic has given us the debrider blades. So without forgetting them, I can't start the demonstration. Now, today's case, I'll read the CT scan for you in a moment.
Lux forceps.
Good morning, Dr. Deepak.
Yeah.
GC Ravi.
Hi, sir. Hi. You are speaking from Chunchandgiri?
No. I'm in the hall.
Oh, okay, sir. So I will come to the scan here. You can change my name from Deepak Haldipur to Deepak Hussain because I'm going to read from right to left.
Oh.
Okay.
Okay, no problem.
So this is the first cut. You can see this.
Live already.
Yeah.
The first cut, 2 frontal sinuses you can see here. You can see the 2 frontal sinuses. The left one slightly less pneumatized compared to the right. You can see the septum is fairly in the center anteriorly. As we go a little back, you can see this is the nasal bones and this is the thick frontal beak. As I go posteriorly, the beak is gradually disappearing. You can see the frontal T here. And you can see this is the last portion of the beak. And in this cut, the beak is disappearing. You can see an agar-nasal cell here. And the agar-nasal cell is leading into the frontal sinus. So probably I expect the drainage pathway to be medial to the uncinate process. You can see the uncinate here coming up like this and causing a small projection, right? And you can see the septum here, which is deviated to the opposite side with a septal spur, which means I will have some room here to approach the frontal sinus. Now look at the maxillary sinus. Initially, the maxillary looks very narrow compared to the other side. We have to be careful about what is called as a silent sinus syndrome. But I don't think in this case that is the fact, because as we move forward, again right to left, you can see that the maxillary sinus is becoming bigger. The opening is becoming bigger.
Yes.
Please, mobile music, please. Switch it off. Yeah. And then this is the opening here. You can see the opening getting wider here and a little wider here. So basically, I have a bit of a roomy space here, except for the middle turbinate, which is amalgamated with the disease. And as I come forward, I mean, as I go backward, I can see the Kennedy's nipple here. Can you appreciate that?
Yeah.
Yeah. So Kennedy's nipple, you can see the medial rectus muscle here, the superior rectus and the superior oblique muscle here, which always points towards the anterior ethmoid artery. So the anterior ethmoid artery is just running a little lower than the skull base, number one, which is good for me. Number two, if you look at the skull base, it looks like Kiros type 1, which is a short skull base. So it is, in a way, it is okay. Please speak. Excuse me, please. Yeah. So the skull base here is type 1. It's not type 3. In type 3, there's a higher danger of me damaging the lateral lamella, and the lamina papyracea is also intact. As I keep moving from here, see, I want the postgraduates to realize the transition from the frontal beak to the frontal sinus or the frontal recess, because the frontal sinus ostium is always posterior and medial. Frontal beak is the floor of the sinus. And this is the, madam, slow. Yeah. So the deviation, septal deviation here, you can see the skull base here, which is W, 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 is suddenly becoming a sloping gentle U and then a flat line. This is where the scans are transiting from the anterior ethmoid to the posterior ethmoid. There are 5 clear points when you see the scan to tell you that you are in the posterior ethmoid. 1, the skull base becomes a flat U. Number 2, the appearance of the superior turbinates. Number 3, the orbits, which were looking very round in the anterior ethmoid, start looking smaller and quadrigonal. And number 4, the maxillary sinus, which looks more quadrangular here or whatever, starts looking oval and smaller. And number 5, the middle turbinate, which was looking vertical in its attachment, is now turned and gone to the lateral wall. So this is the posterior ethmoid. You can see they are pretty roomy. Not much disease in that, again, thanks to the steroids. You can also see the superior turbinates here and the sphenoethmoidal recess, which is the 6th point to tell you that you are in the posterior ethmoid. Now, as I move from the posterior ethmoid slowly, cut-wise here, you can see there is no roof of the choana seen here. This point, you can see the rostrum. You can see the keel of the sphenoid or the keel of the womb or whatever you call it. And then the next slide, you can see a thin bone of the choanal upper border, which means from the posterior ethmoid, in this cut, we are making a transition to the sphenoid. And look at the sphenoid, the left one is roomy, the right one is smaller. As a surgeon, always try to look at this point, because this bone next to the keel, this is the area where you're going to make an entry into the sphenoid. Many times you will see a neo-osteogenesis. And in the neo-osteogenesis, it is difficult to enter the sphenoid. You may have to use the drill, etc. But in this case, again, it appears to be thin. There is no neo-osteogenesis. And so far, it doesn't really look that the carotid or the optic nerve are dehiscent. There is a good bony definition. Ultimately, you can also look at a little bit of adenoids here. So all in all, to summarize, because you need to run through your scans within 5 minutes. You can't spend a lot of time on that. It's a good roadmap. In this case, I have a deviation to the opposite side, the right side with a spur. The lamina papyracea is intact. The anterior ethmoid artery is very close to the skull base. The skull base is type 1 Kiros. The maxillary sinus passage, there is no silent sinus. The sphenoids left is bigger. Both the frontals are pneumatized. Sometimes if the frontal is not at all pneumatized, you trying to poke there in that area, you can encourage a CSF leak. So all in all, looks like a reasonably good anatomy. So I will just start with the case, because FES, though demonstrated many times, the whole theme of this workshop is to again revisit 90% of the surgeries done by 90% of us in 90% of the times in our practice, whether we are in a college or in private practice. I still believe, and I'm sure Sanjay Agarwal and JP Reddy and Harihara Murthy will agree with me, that septoplasty is the most difficult operation even today. When I do it for 1 month, it looks very nice. But after 1 year, I slowly, gingerly ask my patient who did this, because many deviations tend to come back. So I wanted external septoplasty as done by Vishwas. It was a very, very difficult case, I must confess. The cartilage was really broken into many pieces. The additions were too many. So now I will be showing a routine FES on one side, after which Naveen will be demonstrating the endoscopic septoplasty, which is done more and more commonly these days. Hariharamurthy has been my senior. We know each other since 1990. And he is the man who taught me my first tonsillectomy. He held my hands and made me do it. It's an emotional moment for me that Sanjay Agarwal, JP Reddy and Hariharamurthy are moderating this session. I think I'll start now.
Thanks, sir, for your very nice points that you have told the CT scan. And the explanation was very good. Before you actually start in the case, hello?
Yeah.
Can you just...
And I must thank Dr. Rangalakshmi, head of the Department of Anesthesia. But for her cooperation, I couldn't have posted this case at all. Okay, go ahead with your questions. Yes, please.
Yeah. What is the exact preoperative preparation that was done for this patient, sir, for the past 20 days?
Basically, we gave antibiotics.
Okay.
And steroids with the consent of our anesthetist.
Okay.
And of course, at the end of my case, I'll request Dr. Rangalakshmi to speak for about 5 minutes about what all troubles they had to go through to get this case ready.
Okay.
Right, JP? See, are you getting the endoscopic picture?
Yeah, very clear, sir, very clear.
Yeah. See, I have basically what I did was I packed with this one xylocaine, which had 3 ampules of adrenaline. You can see how nicely it is decongested now.
Yes.
Previously, we used to inject. I continue to inject even now sometimes. My guru, Satish Jain, who taught me this endoscopic sinus surgery, he no longer injects now. Correct. Dr. Janki also, I think, no longer injects. They use frank 1 in 1000 adrenaline.
Yes, sir.
Somehow I'm very scared to use that mixture even now after all this, because the absorption through the nasal mucosa is also quite rapid.
Very high. And
so far, using 3 ampules of adrenaline, I have never had to abandon the case.
Okay.
You know, I take a 30 ml of the 4% xylocaine and put 3 ampules of adrenaline into that.
Okay.
And I've had a reasonably avascular field.
Yeah.
The polyps are also nicely decongested.
Yes, sir.
I think I will start, JP.
Okay, sir. Okay, sir. So in this case, you are not infiltrating?
No, I have infiltrated a little here. I can't be lying to you.
Okay, sir.
I've infiltrated a little here.
Horizontal part of the
SMR elevator. What I did was, I infiltrated to the upper border of the inferior turbinate.
Okay.
And used my SMR elevator like this and out fractured the posterior and lower part of the inferior turbinate here.
Yes. So that you will get a very good place to work actually.
And
that's the most important.
I injected a little in the septal tubercle here.
Okay.
And then I massaged this area, you know, which I learned from Professor Milind Kirtane.
Okay.
So what you do is you press here. Again, you get a good view of the axilla.
Excellent.
Yes. Okay.
Yes, sir.
So
yes.
you can see the uncinate ball probe. So right now my landmarks are the middle turbinate, the posterior end, the anterior end, the axilla. This could be the uncinate. You know, you can see the whole thing moving here.
Yeah.
Yeah, this could be. So this is the line here where probably, you know, I'll try to, let me see if this looks like the free border of the uncinate.
Yes, sir.
I'll take away the polyps a little bit. Debrider, please.
Deepak.
Yes.
You said you used xylocaine and added adrenaline.
Yes.
Since the patient is under general anesthesia, why you want to use xylocaine instead of using only saline?
Yeah, see, xylocaine and adrenaline, they work synergistically, sir. If you remember, whenever tachycardia occurs also, our anesthetist immediately gives xylocard. So,
no, sir, some people say that if you add 4% xylocaine to the adrenaline, you can reduce the analgesics that you are giving intravenously actually.
Okay.
The amount of analgesia what is required in during anesthesia drugs can be reduced by using local anesthetic. That is what is the another answer for that, sir.
Yes.
Some people don't use adrenaline, xylocaine, but I think reasonably if you can use small quantities, they can actually reduce the anesthetic drugs actually.
Yes. No, but I've been using this.
Yeah.
They work synergistically, I feel. Yeah, you can use it with saline also. Nothing wrong.
Yes. Yeah.
Yeah. I'm just debriding those polyps
Okay, sir.
so that I can approximate the natural anatomy. Yeah. I think we have removed those polyps, correct?
Yes. Yes. Yes.
Yeah. Ball probe. See, ultimately, surgical demonstrations are like a T20 match.
Yes.
No matter what you are on that day, your luck has to hold out.
No, sir. The selection of cases,
This is
preparation
ball,
of the
this
case.
is the, yeah, this is the bulla,
Bulla. Yeah.
and this is the groove here. See the hiatus
Hiatus.
semilunaris, where I'm
Yeah.
going into the ethmoidal infundibulum.
Yeah.
Again, because of the polypoid mucosa, the space is less.
Yeah.
I can either go here or
Yeah.
I can do a backbiter here.
Yes.
I'll try for a backbiter first, Nagashima backbiter. So first I'll try with the Nagashima backbiter. Every department feels this is their instrument. My gynecologist friend said this belongs to gynec because backbiting. We felt it is ENT. Just a joke.
Very
But,
good instrument.
the
Very,
second
very
one-
good instrument.
See, the second bite I'm taking at 45-degree downwards to avoid injury to the nasolacrimal duct. Okay? See this. Ball pro debrider kodu. JP,
Sir.
now I'm trying to debride the mucosa here.
Okay. Yes.
So this is the mucosa medial to the horizontal part of the uncinate. I'm trying to debride that.
So that you can remove the horizontal part with the
Yes, yes,
meter.
yes.
Yeah, yes, yes.
This is a totally Indian technique. You know why?
Yeah.
In US and all, they don't do this because for every case, they're supposed to use one blade.
Yes.
We are the Indian Jugaad. We use one blade for 20 cases. So
Yes.
if you have to save the blade, you have to debride the mucosa and not the bone.
Yeah.
All
Sir,
pro-
there's, sir, one more question to you. These
Yes.
blades, once you are used, so you will send it for ETO sterilization, or how do you sterilize this?
In Trustwell Hospital, I have ETO sterilization, so I do it.
Okay.
But in a
Otherwise,
smaller setup, you can even use your formalin chambers.
okay, okay.
Unless you are doing a case of CSF leak repair,
Yeah.
then you know you better go for a good proper
New
ETO
one, new one. Yeah.
Otherwise, the nasal mucosa has so much of organisms,
Yes, yes, sir. Yes, sir.
isn't it? Straight grasper, 40-degree blade haku. So see, it is nice to say ETO, which is ideal, but how many setups have it, JP?
Yes, yes, correct, sir.
I only now, after so many years, now in Trustwell have that facility. Otherwise, all the other hospitals I operated, that was not there.
I think the formalin chamber is okay, and the
Yeah.
next option will be you can use something like Paracef or something like that. You can
Yes.
soak the blades for about
Also-
20 minutes,
Yes.
Sidex or something like that.
Yes.
As Dr. Deepak said, the nasal cavity already had a lot of organisms. It's not a sterile area.
Yes.
The only concern is disease transmission from one person to one person, like HbA or some kind of a viral infection.
Yeah, yeah.
Otherwise,
No, no. See, ideally, if you have the access, nothing like ETO.
yeah,
But practically, in our
Yes, sir.
country,
yes,
is it possible for all the surgeons to get it?
yes, yes.
Yes.
There's a
Debrider?
nice polyp sitting in the maxillary sinus.
Yes, 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 yes.
Yeah. So now at this point of time, sir, the posterior frontal lay, is it
Yes.
better to use a through cutting instrument or a debrider here?
You
taken
can
up
use
40.
there is one wonderful instrument called the seal cut forceps.
Okay.
But true cut has to be good. Then it is okay.
I think
But the problem is true cut instruments don't last for a long time. JP.
yes, yes, that is the thing. So it is very
Again, the
expensive.
expenses come into
Plus,
play.
they don't last for a long time. Correct.
Yes.
I
Straight
think what you have
grasp-
done is excellent. The 40-degree
Yes.
is an ideal tool to do this job.
Because you're also from my college, BMC, and you're my friend, you're telling good things.
No, no, sir. This is actually, see, every bit of the thing we learn new things. Actually, now this step I used to do with RAT 12 actually.
Yes.
Now I understand that RAT 40 is easier than that.
Yes.
Yes. Nice.
Rad 40 is a versatile blade.
Yeah.
I used to use only, 0 or Rad 12, something like that.
Yeah.
Our Arshad, he started using it more frequently.
Okay.
And of course, my guru Satish Jain,
Yeah.
so now I'm into this maxillary sinus a little bit.
So do you use the lot of irrigation channel with debrider, or somebody will pour you saline inside?
No irrigation. It is ideal to use once in a way. But otherwise, if it is not bleeding, no need to use. But in between, you can irrigate.
Okay. Otherwise, we have a irrigation channel also to the blade actually. Do you use that routinely, sir?
Which one?
See, there is an irrigation channel to the blade and you can connect it to
Yes,
the
that we
saline.
use.
Are you using right now?
Yes, very much.
That is what I am asking. Yeah.
Very much.
Yeah. So the advantage of that is it will prevent the clogging of the blade, and the operative site is very clean and the bleeding will be reduced.
Yes.
Actually, this Merosil packing is an excellent idea of blade. It is super. It is amazing. It does lot of wonders actually.
Yes. See, I'm gently now taking the mucosa away from the middle part of the uncinate. Okay?
Yeah.
You can see the uncinate here behind the bony part. I'm taking away the mucosal part, debrider. I must confess the anesthetists have given me an excellent field. You can make it out, isn't it? Hari, JP?
100%. The anesthetists have done a great job. In spite of patient having so many issues, and field is superb.
Yes.
In spite of lot of inflammation the patient had.
Yes.
And it is reasonably very good field actually.
Yes. Absolutely. So the whole idea is
that
I'm almost hugging the ascending process or the frontal process of maxilla.
Yeah.
So that I get maximal visualization before I proceed further.
Yes. Sir, do you have any experience of operating this kind of a minimal disease patients under local anesthesia if possible?
Local I have done before, and manual instruments also I have done before.
No, sir, actually, once you are used to this GA, it's a luxury to operate. And it is really stressful to operate under local anesthesia, sir. Patient is moving and then bringing out lots of blood. You can't irrigate.
Yes. And more than that, JP.
Yes, sir.
Every procedure, small or big, even giving an injection, is fraught with risk.
Yes.
If you have a good anesthetist with a tube in place, you can save yourself a lot of trouble.
Correct.
So I'm a very big proponent of general anesthesia.
Okay.
I hardly do anything under local JP. I know you will fire me. Even the stay piece I do under GA.
Oh my God. No, sir. What you are doing is absolutely correct, sir. The thing is, if you have a very good team of anesthesiologists, and once you have the luxury of operating under anesthesia, you know, this patient is moving, bringing out some blood, and all these things.
Taking away this portion of the uncinate.
Very good. So you are removing layer by layer, actually.
Yeah.
Very precise and very nice.
Yeah. Debrider. See, because one thing I'll tell you very honestly, at the end of the day, you need a little bit of demonstrator's luck.
Yes.
You know, because if it starts bleeding torrentially, what will I be able to see here?
Nobody can do anything, sir, especially in a polyps case.
Yeah.
It all depends on the pre-op preparation, and everything depends on the anesthetist.
So Dr. Rangalakshmi and her team, Dr. Ambarish, etc., you know, they have done a fantastic job.
Yes. Almost zero bleeding, I can tell. Really.
Yeah. Array with Sanjay Agarwal, Jaiprakash Reddy and Harir Murthy sitting there, who are my true well-wishers, where will I get a problem, man?
And you are so lucky to have deviated nasal septum to the opposite side. you have selected a very good patient, sir, actually. When I saw
select, you know that?
No. When I saw the pre-op CT scan yesterday, then I imagined the surgery is going to be fantastic in your hands.
Yes.
Sir, now can you just explain, sir, what is the best way of opening the bulla actually?
Right grasp.
There
Yeah.
are, even though there are many
Yeah.
ways and means to do that,
No,
which
in
is
the
the safer and the best method?
in the beginning of my career,
Yeah.
I used to go through this, ball probe.
Infromedial aspect, or
I would use a suction and
Yes.
puncture this area
okay.
inferiorly and medially.
Now,
See what I tell everybody, the moment
Yeah.
you do a middle meatal antrostomy,
okay, sir.
you concentrate on this point,
Okay,
the
maxillary line.
junction of the roof
Yes.
of the maxillary sinus and the medial wall.
Yes, sir.
All your openings from now on up to the sphenoid, if you do it around this line,
Okay, below
or
that.
little below it, you are very
Yes,
safe.
safe. Yes.
If you poke from here, sometimes you put excessive force.
You will go into the
Or if the
lamina.
bone is thin, you can go through the posterior ethmoid also,
Yes.
and you'll be confused where you are.
Yes.
The best is to go behind here,
Then pull it forward.
break the wall, anterior wall from back to front.
Yes.
Like
Ideal.
this, no?
Yes.
Like this, see.
Yes. This is
Like
the safest way to do this. Yeah.
Yes. This is better because that way you can locate the posterior wall of the bulla.
Sir, this can be done if there is a retrobullar space is there actually.
Yes,
If there
yes.
is no space, how do you do that, sir?
Then at least you know that this both walls are the same and that's the ground lamella.
Okay.
But at least you are not accidentally poked through the posterior wall, no?
Yeah. Correct,
Which is
sir.
what you want to avoid.
Out of the two techniques that we have, I
Yes.
think this technique what you have done is the safest and the best one.
Yes. Because you better come through that and come forward.
Yes. So posterior to
Also-
anterior is always safer than anterior to posterior actually.
Yes.
So that point has to be stressed, sir.
Yes. What degree forceps?
Sir, while doing this anterior ethmoidectomy or opening of the bulla,
Yes.
so what are the complications that can be created by a surgeon who started his career?
See, first thing is,
Yeah.
it is important that you remove that much bulla to create a space for yourself,
Okay.
but you retain the upper wall here, this one,
Okay. Okay.
to locate the anterior, the frontal sinus.
Okay. That's
What I
intact bulla
call the
technique if you
intact
are
bulla
following.
technique.
Yes, very good.
So what I will do is just about, remove the polyps within the bulla,
Okay.
okay,
Okay.
and keep this wall right now,
Okay.
but take away the inferior wall
Okay.
and the medial wall so that I have enough space to work towards the frontal sinus.
Okay.
Okay.
Okay. Sir, my question is,
Yes.
what are the structures at risk when you are opening the bulla ethmoidalis?
If the upper part, if you don't retain
Okay.
and you poke through that, you can damage the anterior ethmoid artery.
Number one.
Number two, you can go through accidentally into the posterior ethmoid,
Okay.
and you will be lost initially because you don't know whether you're in the posterior ethmoid or then in the sphenoid.
Okay.
You can also damage the skull base
Okay.
if you go up. And if
Okay.
you stay laterally, you can damage the lamina papricia
Yes.
and get into the orbital fat.
Yes, sir. These are the
Okay.
four structures. So always we have to be
Yeah,
inferior-medial.
ball
Yes.
See, JP, the first surgery, I say, it's a surgery of a square.
Yes.
The square contains two green lines
Okay.
and one yellow line
Okay.
and one red line.
Okay.
See the square.
Okay.
You operate on the green line here,
Okay.
green line here, you are safe.
Yes.
You operate on the yellow line, you can create a CSF leak.
Careful. Yes.
It can be repaired on the table.
Okay.
But this is the red line.
Okay.
The three important structures, the medial rectus, the optic nerve, and the carotid,
Okay.
can be damaged when you cross the red line.
Red line. Yes.
So lateral, no. Like our teachers used to always say, no, when you go to school or when you are studying, you look at a straight line. Seedha nodkondu hogu.
Oh, correct.
Oh, don't look laterally.
Okay.
Yeah, see, this is my bulla upper surface.
Okay.
If I go here, I will find the frontal sinus.
Okay.
Okay. Deep breath. So I'll keep the anterior wall of the bulla intact right now.
Okay.
The upper portion. I'll keep two sponges here. Sponge. And our ENT department in Rajarajeshwari is extremely supportive, JP.
Very good, sir.
And because Srirang Prasad and TM Nagaraj and me also studied our PG together.
Sir, Srirang Prasad was my classmate during MS, sir.
Yes.
Prasad and myself, we have cleared MS together in
Ambedkar College, no?
No. We appeared for the exam in BMC.
Okay. Sriranga was my classmate when he was doing DLO.
DLO, correct.
And
very nice man, silent man.
Yes.
So now we are left with only the superior most part of the bulla, sir.
Yes.
Yeah.
See, this could be the Agarnesi area.
Yes, small Agarnesi was there, you said.
Yes. Ball probe.
Still you are using 0 degree telescope only.
Yes. See, remember as a beginner,
Yeah.
better to do maximum surgery with 0 first.
Yeah.
And then, try and do other things, Because
now
it
you are
gives
removing the posterior wall of the
orientation.
bulla, no, sir?
Yes. Now no, I'm basically removing the superior wall of the bulla.
Superior wall of the bulla, yeah.
Yeah, see here, which I kept intact because when you run it along, you go towards the frontal recess. It's a natural landmark.
I think the frontal recess is
and
open.
it
actually.
also protects your anterior ethmoid artery from damage.
Yeah. I think it's a frontal recess come into view now.
Maybe, with 0 degree, see, with 0 degree.
Yes, that's what.
Debrider. So I encourage all the beginners to use maximum 0 degree. Of course, you must be adept at using the 70.
Sir, actually, in this patient, there was not much frontal sinus pathology.
Yes.
So even if you don't open also, is it okay, sir?
No. See, the inlet should be clean, boss.
Okay.
You saw so many polyps.
Yes.
And in polypoidal disease, whatever you remove and what you leave is going to next become hypertrophy.
Okay.
So you better make sure it is open.
Yes.
Okay.
Yeah.
Now
I think
I'll put the 70 degree and try to visualize the inside of the frontal.
Yeah.
70 degree. Because I believe, JP, that we are now more than 22,000 ENT surgeons in the country. We should all be able to do a good, safe FES and a good endoscopic septoplasty. Because skull base and all is done occasionally in setups which are there for that. But our population still needs a good, proper FES, Can you see the frontal? JP?
It's very clear, sir. Very clear.
Very clear?
Very clear.
Well mucosalized, no disease inside. I won't go further. I won't meddle further.
Yeah.
Okay?
Very nice.
Yeah.
I think if you can remove that bony specule superiorly, I think you're done.
Yes.
You want to irrigate or see something is there, sir?
No, 60 or 40 degree blade. No, irrigate also not required because the current scan clearly shows.
Yeah, it's nothing there.
Yes. I just removed a little bit of the mucosa which was projecting there. I'll remove these bony spicules. That is the bony spicules which are protecting me from the anterior ethmoid artery and the supraorbital cell. That is why that area I am touching last. Okay? Hello? Hello?
Yes, sir.
Yeah. See, this bone I am removing last.
Yeah.
Because that is the one which was protecting my anterior ethmoidal artery.
Correct.
Okay?
Yes, sir.
45 degree debrider, please. Ball probe. I am still with the 70.
Excellent, sir. You are preserving the mucosa in that area.
Yeah. No, that's because of the debrider.
Yeah.
If
you, I think if somebody, I've seen people who strip the mucosa, there will be granulations over the raw bony surface post-operatively
Yes,
that
yes,
don't
yes.
heal for a very long time. It will lead to a lot of crusting
Yes,
and
yes.
lot of issues in the post-operative period.
Grasper. Yeah, no, I think by and large, if you use a debrider and if you are a little slow with your technique,
yes,
mucosal preservation will happen.
Yeah.
I have just two more sinuses to go, the post-ethmoid and the sphenoid. Then Dr. Naveen will take over. Naveen, if Dr. Vishwas wants to speak something to the audience, you can shift
if
the
he's
audio
ready
for
with
2
the,
minutes.
he wants to say something. I think he has taken some, he's doing osteotomy, sir.
Yeah, just, we'll give audio for 5 minutes to Vishwa.
No, you are opening post-ethmoids now?
I will do that. Before that, I'll take out that bony spicule which you ordered.
No, sir. When you are opening the
I will come back. I'll come back. I'll come back.
In that case, we can go to the other.
Yeah.
Can we ask the audio people to switch over to the other OT, please? Hello?
45-degree forceps. Yeah. Hello. Audio उस तरफ shift करना.
Hello.
Yeah. Can you just tell us what exactly was done all this time and now what you are doing?
Jai Prakash, sir. Good morning.
Good morning,
sir,
boss.
Yeah, sir. Actually, this patient has a tilted convex deformity on the right side and concave deformity this side, and the nose axis is shifted in this direction.
Are you using endoscope to show that part?
No, sir.
You are using head cam?
VTOM, sir. VTOM.
Yeah, you can just move a little bit forward from the patient so that zoom out.
Zoom out, sir.
Yeah, little so that we'll get oriented. Actually, the picture is very clear. If you can zoom out a bit, it will be more. We are able to understand better than.
Yes, sir. So herein we are going to do asymmetric osteotomy, sir.
Okay.
Because the bone is shifted like this.
Okay.
In this direction. So I'll be doing a medial, that is a paramedian and a lateral osteotomy this side, so that the convex edge goes in.
Okay.
And here I'll be doing only a lateral osteotomy and a root osteotomy. So I go in and release that curved tilted septum assembly, or rather the nasal bone and septum assembly. So when I release that, this part of the nasal bone is still attached to the bony septum and the central skeleton, and this shifts back to normal when we do a root osteotomy. So I don't do the paramedian osteotomy this side. I just do it on the right side and lateral osteotomy here. So this segment is free and it is dipped inside already. We can see it here. Now this segment, sir, only lateral osteotomy and then root osteotomy going inside. Going inside onto the bony septum. So once I go inside onto the bony septum straight down, the whole skeleton that side becomes free. So what is tilted like this can be repositioned like this, and this part which was tilted like this comes into alignment. So that's what I'm doing right now, sir.
Okay.
So percutaneous osteotomies are preferable. They are stamp size osteotomies which walk on the bone after reflection of the periosteum. And we stabilize the head with one hand and ask the assistant to tap with other hand on the opposite side. Tap, 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 tap. The second tap, is the harder tap. Tap, tap. And that's when we listen to the coconut shell breaking kind of sound. Tap, 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 tap. So at no point I've done any medial osteotomy on this side. Just retaining that segment. So that entire tap, 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 harder, tap, 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 tap.
Yeah, can we go back there?
Yes, sir.
Yeah.
Yes, sir. Tap, 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 tap.
We'll see you in the picture-in-picture.
Yes,
and
sir.
the audio will be shifted, but
Tap,
we'll
tap.
continue to see your surgery.
Yes, sir. Tap, tap.
When any important step that you want to show, you can always ask us so that we can switch
Tap,
over
tap.
the.
Tap, tap.
Yeah,
Tap,
can
tap.
we
Thank
have
you, everyone.
audio onto
Now
the
we
other
shall
OT,
resume back
please?
to the surgery by Dr.
Yeah.
Deepak Khalid.
Tap, tap.
Sir.
Yeah.
Thank you.
Hello.
So, Dr. Deepak sir, we are with you now.
Yeah, can you hear me, JP?
Yeah, very. Can see you also very nicely.
Yes.
And frontal is well opened.
Yes.
And
45
now,
degree forceps.
yeah.
JP, that is the uppermost part of the anterior wall of the bulla.
Yes.
I'm taking away this bone.
Yes. Now the frontal recess becomes more wider even. Once you
Yes.
remove that. Yeah.
Debrider.
Good morning, Deepak. Hari here.
Hello.
Harihara
Morning.
Murthy sir, namaskara.
Good morning.
Oh,
Namaskara, JP.
namaste, boss. Namaste, namaste, namaste. So, JP,
Sir.
now I'm working near the anterior ethmoid artery area.
Okay, sir.
Bone punch. ತುಂಬಾ ದೊಡ್ಡದಿದೆ, ಇರ್ಲಿ. These punches are also very good instruments.
Super.
Very good through cut instruments.
Yes, sir.
You know, for
many people actually don't use this, but actually there's very good.
Very good instrument.
Yeah, very precise and yeah, I think some wide cell got opened there.
Yes.
Yeah. Is it posterior part of?
Yes.
Post-ethmoid's upper part, I
Yes,
think.
no, this would be the anterior ethmoid only in the upper part. We are still,
Yeah.
upper border of bulla here. See,
Yeah.
this part I'm taking out now, JP.
Yes, sir. That mucosa can be. Yeah.
Yes.
Yes. Oh.
See that?
I think all medication has done excellent section. And is really lucky to have it. Yeah.
Yeah. Suction block agide nodu, blade block agide kana Manu.
When you want to open a cell and
Yes.
when you see the nature has done this, you are so happy.
Yes. But for nature, we would have been less than mediocre surgeons.
Yes.
It is nature which makes us appear better.
Yes.
And look at the engineering, look at the stars monitor.
Yes.
The endoscope, the magnification, the play of colors.
Yes.
See the posterior table, color of the posterior table. Look at the lamina papyracea looking yellow laterally.
Yes.
Look at this cell with a light blue hue.
Correct.
You can see the skull base. I think basically we are all very fortunate to be working with these equipments,
Yes.
this kind of anesthesia.
Yeah.
And the patients gives you credit for nothing actually.
Yes, sir. Correct.
Yeah.
The 4K camera what you are using is really amazing, sir.
Yes. See how one by one, that is a supraorbital cell, JP.
Yes, sir. Yes, understood. Yes.
Yeah.
Yes.
That's a supraorbital cell, which means our anterior ethmoid should be in the posterior border here,
Yes.
where I'm using the debrider now.
Correct.
Deepak,
Yes.
you have been very humble in saying that we are only fortunate. I think you are like that F1 driver,
Huh?
You have actually mastered the skill that you're able to give away to the people sitting and watching you.
No, boss.
And all these other things are additional embellishments, which help you do that.
No, boss. That's really nice of you to say that, Hari, but straight grasper.
And what JP said earlier was very true. Using those true cut instruments makes it much better, especially when you're using a debrider. You don't have to go
Debrider?
with a debrider. With the true cut instruments, you can actually stomp on all those structures and make it easier for you to take it out with the debrider. And you're not cutting through any structures or messing with any of the structures you don't want to, you know. We have seen enough mishaps happen because of inadvertent use of the debrider.
Punch. Now I'll move on to, I'm on the 0 degree scope, JP. Hari, I'm on the 0 degree scope now.
Yeah.
Yeah.
I'll move to a 0 degree blade as well. Sponge kodu innondu. Sanjay Saab.
I think when the small cell is there and you want to open it widely, I think if you can pack it with what you are doing, that will do the job also, actually.
Yes, absolutely.
When you want to open the post-shut minds, you can push this inside. I think half of the job it does.
Yes.
It is only the planes that we need to know how to elevate and then how to create actually.
Yeah.
Instead of poking here and there, I think you'll have to remove by one lamella, another lamella.
That way it is more aesthetic and neat, you know.
Yeah.
And the surgery is less bloody and easy to.
No, sir. The rule of ear surgery is to move from one known landmark to another known landmark.
Yes.
By noting it, the relationship between each other. So in the same way, it applies to the nasal surgery also.
Till we get a Google map for that also.
Yeah.
No?
Yes.
Suction block ಆಯ್ತು ನೋಡು. Naveen ready ಆಗು wash ಮಾಡು. Wash ಮಾಡು. ಟೇಡ ಮೇಡ suction.
Yes. So now
you can appreciate the
you
can appreciate the ground lamella
very clearly. Yes, sir. Now can you enlighten the this one? What is the safest way to open into the post-shut and please show the basic landmarks and then go about.
Remember JP,
you said that line is there.
Even if it is a 7th revision, 8th revision, the middle meatal antrostomy will always be there.
Yes.
So look at this maxillary sinus. You're able to see that.
Yes, sir.
You see the junction of the medial wall.
Okay.
And the superior wall.
Roof.
Wall probe. Yes. So that is your maxillary line.
Okay.
See, this is your maxillary line. Horizontal.
Okay.
Okay. So you can open up here.
Always below that.
There is no retrobulbar space here. Can you see this?
Yes, sir.
If there is a retrobulbar space, it would be found behind this posterior wall of the bulla, which you have left intact.
Okay.
There is no retrobulbar space.
Okay.
So now you can again go here, open it up here.
Okay.
Just the way I tell you, go in like this and come forwards, you know, towards you. It's always safe, lamella by lamella. Can you see this?
Yeah.
Huh?
Okay.
I feel this is a good technique.
Yeah.
You know,
posterior to anterior.
Yes. Posterior to anterior. You come like this. Okay.
Yes, sir.
And then take out that bony lamella, then use the debrider.
Okay.
Mucosal preservation becomes that much easier.
Okay, sir.
Okay, 45-degree forceps.
Sir, do you have any experience of using this quadra cut blades? Nowadays, they have come new ones. Do you use them, sir?
Which one?
So now we have tri-cut blades. Like that, there are quadra cut blades have come into the market now.
I have not yet used, but shortly, definitely I'll be using.
Okay.
Because any new instrument comes to the market, I buy it first.
Okay, sir.
You remember in 1994 April, I got fired by Dr. Madhavaya for buying the endoscope.
Yes.
Yeah. Time moves fast. Debrider. Anything new that comes,
this actually, sir, this quadra cut blade comes in 2.7 diameter one also. Very small, slender one. It's very easy to use, sir, actually.
Yes.
And you can use in a child also. And you can use in even if there is a lot of difficulty to use or less space also you can use actually.
Yes. Bone punch. I am very close now to the posterior ethmoid and sphenoid, JP.
Yes, sir. Yes.
I will finish probably in another 10-15 minutes.
Okay.
Naveen is washing up already
Okay.
for the septoplasty, and believe me, he does a fantastic job of endoscopic septoplasty.
Okay.
He is very, very good.
So we'll see him in action in a few minutes time.
Yes, yes, 10 minutes time. You can see
Yeah.
the lamina papricia here, the yellow
Yeah, very
color.
clear, very clear. Yes.
Yeah. I'll just break these partitions a little bit. 45-degree forceps.
Sir, I think the surgery is all about the patients that you are the precision you are doing. And I think we need to do surgery like this. You can enjoy. Otherwise, in a hurried thing, if you want to go and then do something, and you want to say that you have finished surgery in 5 minutes or 10 minutes, I think it is not done. I think the surgery should be done in a way like this, so that you can really enjoy the surgery.
Yes.
Now I think you have opened one cell.
My senior Vijendra sir always tells me, surgery should be like a meditation.
Yes.
Look at the posterior ethmoid there, JP.
Very big one. Yes, yes.
Yes. Right. Yeah. Probably this surgery is 60% of the ear surgery what JP does. It is like that. Isn't
Sir,
it?
actually, this microdebrider you are using.
I've seen your ear surgeries. They are so fantastic.
Yes, yes.
A pleasure to watch.
Sir, actually, the way you are using the microdebrider to dissect and also to break the lamella is very nice.
This again something that I learned from Satish Jain.
Yeah, I've been watching this. You are using that to push the lamella and to dissect also.
Yes.
It's a very nice way of, instead of using another instrument, so at the same time, you're doing both jobs actually.
Yes. Bone punch.
Sir, this bone punch is 2 mm or 3 mm?
This is about 2 mm. Yeah.
2 mm. Okay.
And if you leave those upper lamellas, no, JP, till the end,
Sir.
you have landmarks always to look for.
Yes. At the end, you can always.
Yes, this I learned from Stamberger.
Yes, sir.
If you leave this here, see, you know your anterior wall of bulla.
Yes, where you are.
This,
Yes.
the
limit. Yes.
Yes, and this, you know.
I think at the end of surgery, you can conclude them.
Yes. Straight blade. And always your landmark is in your maxillary sinus.
Yes.
That point which I keep on harping about.
Yes, sir.
So now with the posterior ethmoid, we know that the border here
is
the
superior. Now we are
turbinate.
going to the sphenoethmoidal recess, no, sir?
Yes, superior turbinate. Yes.
Yeah. Sir, actually, now I just want to ask you one question. You want to open a sphenoid sinus from the ethmoids, or you want to do a, I identify the natural ostium and which is the best way according to you?
Natural ostium is the best way.
Okay.
Natural ostium is the safest way.
Why?
The best way, because you are going medially and inferiorly, no?
Yes. And one more thing is that even if there is a one-body situation also, it's always safe to open this way.
Yes. See?
I think, yes, you are already.
Yes. Can you see that?
Yes, already. Yes, sir. You are pushing and then doing. Actually,
yes, use the blunt end of the debrider.
Yeah, debrider to actually push the, lamella.
You can already see there.
Yes, sir.
I'm almost done, JP. Another 5 minutes, I'll be done.
Yes.
I don't want to overdo something.
Yeah.
Because.
So now, sir, when you are opening actually into the sphenoid sinus, what is the structure at risk and what precautions that we need to take, sir?
See the septal branch of the sphenopalatine.
Yes, that is the
one
most
at risk. Number two, if you go laterally, you can always be troubling a dehiscent carotid.
Yes, sir.
Sponge.
Sir, actually, this posterior septal artery had caused a lot of problem to me once. The patient had a post-operative massive hemorrhage, 7th day following surgery.
Yeah. And even small arteries can bleed quite a bit, you know.
Yeah.
Especially so 7th day, because when the crust falls,
yes, sir.
The arterial end becomes very big. On the table, it would be very small, actually.
Yes, sir. Correct.
You would have neglected it. I have done it so many times.
See, now
I thought something is a small vessel.
Yeah.
And on 7th post-op day, the same vessel bleeds like hell.
Oh my God. That to the patient will always come in the odd hours, putting you at real risk.
And see, the moment we see it's an unexpected event, no.
Yeah.
7th day bleed, neither the surgeon has expected.
Yeah.
No matter whatever we are talking, our facial expression tells the patient
My God.
that we were also not prepared for it.
Correct.
Debrider, straight grasper.
Actually, what you have done is a very nice step that you want to do a sphenoidotomy with the. This will really do a traumatic way of sphenoidotomy by pushing. So just whenever you want to remove any cell or anything, if you push the gel,
blunt end. Yeah.
This one. So it will be a very good technique to actually enlarge any small cavity. Actually, it can make very big in a traumatic way.
Yes.
Very nice demo, sir. I learned a lot of new things today.
Hey, come on.
No.
We all know that you are a ustad.
No, sir. Whatever ustad is there, teacher is a teacher. Very nice.
Yes. -45-degree forceps.
Sir, when such bleeding occurs from the posterior septal artery, so how do you manage that, sir? Do you use a coblation or do you...
bipolar cautery?
Bipolar, okay.
Yeah, or you can even put pressure for 8 minutes.
Okay.
But best is to cauterize it because, as you correctly said, once in a way, a patient will bleed on the 7th day.
Bah, really horrible, sir.
Yeah.
Whatever bleeding occur, they always come in the early morning, sir.
Yes.
I don't know the reason. All patients that had problems are in the 4 a.m. They come.
Because my experience has been, nature doesn't like a very confident surgeon.
Yes.
Whenever I have felt overconfident,
yes,
nature has corrected me. This has been my experience. I'm telling you very frankly.
They will make you more cautious. Actually, sir, such incidents will make you that we have to take care of the things, minute things also. You should never neglect, actually.
Yes.
Unless anybody has a complication, they may laugh at you when you are telling, but really when they face it, really they know. Actually, that patient, what bleeding I had, I took the young patient. I took the patient under local anesthesia. By the time the anesthetist came, I coablated actually that area.
Okay.
I took a evac.
Coablator is another wonderful instrument.
Yeah.
JP.
ProSize EZ band EZ View is a very good band which can fit into the nasal cavity. It's a small one than actually the evac 70. It has done the job.
Yes.
Do you use this coablation, sir, when you do sinus surgery anytime?
Yeah. I don't. I use it mostly in CSF leaks.
Okay.
And anything which is vascular, coablation is the best.
Okay.
Because see, one advantage with coablation, it can get into the nasal cavity easily. I struggle with the bipolar, the two prongs.
They close each other when you go inside, actually.
Yeah.
And the only instrument that can reach the target, suck as well as coagulate is the only instrument is the coablation, sir.
Yes.
It's a wonderful tool when you are in really trouble.
Yes. Now I'll widen the sphenoidal ostium.
Yeah.
Deepak.
So which is the best way to widen, sir? Direction of widening?
Direction of widening, first you take a look into the sphenoid.
Okay, sir.
And then you can widen in any direction. But before, it should be always medial.
Okay.
Inferior and medial.
Safest, correct.
Our primary school teachers used to say, Taggi baggi nadibeko.
Oh, correct.
One punch.
Dr. Deepak.
Yes.
Good afternoon. Srina here.
Hello.
Namaskara.
Namaste, boss. That is the big boss. You came now, is it?
Yeah. Sorry, I was a little bit late.
No problem.
I had some commitment there.
JP,
sir.
Dr. Srinivas and me, we have really shared some real good times together. On record, he was the best PG in our batch.
Oh.
Simply brilliant. Now his son Anup is also doing very well. Where is Anup now, Srini?
He's still in Bombay.
One punch.
Sorry?
Good view of the sphenoid, JP?
Yeah, we can tell. So I think the sphenoid septations are more. 3 septations were there actually in CT scan.
Yes.
I think there is
Yes.
no need to remove the septations, I think, in this
Yes,
patient.
no. That will be an overkill.
Yeah.
That will be an overkill.
Yeah.
You know, you should love your surgery, but you should not fall in love with your surgery.
Oh, my. Very clear.
All
And
true.
yeah.
Yeah. See the difference in colors.
Yes.
Look at the ethmoidal skull base in the posterior fovea. -45° forceps. Straight. So this is a routine surgery that all of us will be doing many times.
Yes, sir.
If it can be done reasonably well like this, it should be more than enough. You know, debrider.
Deepak,
Yeah.
can I request you to put your scope a little into the ostium you've created? It will give a better view of the entire sinus.
Hari, can you be a little louder?
Could you put the scope into the ostium you've created? It will give the observers a better view of the sinus. Great. Thank you. Thank you.
Actually, that bony lamella has to go a little bit actually on the lateral part. Then only you can see the complete sphenoid. Actually.
Yeah.
I think you can use a punch or something like that. I think.
Yeah. Straight grasper.
Beautiful dissection as usual, Deepak. It's a pleasure to watch you operate.
Thank you, Chief. It's all your training. You need
You're very
you
kind.
deserve all the credit. Naveen washed up? Oh, good.
Sir, do you routinely pack or you don't pack this cavity, sir?
I routinely pack, boss. I'm a private practitioner.
What do you do?
I
with the
would
pack?
like to, we put Mirocell only. I will show you now.
Sir,
Naveen will show you actually.
Sir, do you actually use some kind of a Stamberger foam or some kind of a nasal stent which has come into the market? now? It's
Nothing.
Very nice, actually.
One Mirocell cut into two, put in two nasal cavities if you do bilaterally.
When do you remove that?
Bone punch. We take a 10 centimeter Mirocell.
No, when do you remove that?
Cut the first 4 centimeters and use it as the small packs which you saw during the surgery.
I know.
Yeah.
And the rest of it you put it in the nasal cavity?
Yes.
No, do you pack anything into the sinus cavity?
No. We put, in the same Mirocell. Naveen will show you a single Mirocell.
Okay, sir.
From the coina, coming all the way up till here, you know.
Okay.
Yeah.
And when you remove that?
We remove it 1 day later, 24 hours later.
Okay.
If we feel that there has been too much of bleeding, if the patient is on blood thinners, then we remove it after 48 hours.
Okay.
But if it is some dissection like this where we feel we have not damaged any of the
vessels,
partitions, vessels, 1 day pack is enough. Ball probe.
No, sir. Do you think that this naso stent, that sponge will help us?
Yeah,
in any
why
way?
not? Why not? Anything. See, as long as the patient can afford,
Yeah.
you can always put better materials.
Okay.
Otherwise, even a ribbon gauze, pack it gently, delicately, it is good.
Yeah.
After all, first 10 years of endoscopic surgery, that was the only thing available.
Yes, correct.
we
Nowadays,
did
lot
that
of materials have come into the market.
Yes.
Otherwise,
It's like a 40-degree blade. It's like a power steering, you know.
yeah.
We have used cars without power steering before.
Yes.
So,
It's all the comfort for the
we
patient.
still traveled from Bangalore to Kurnool comfortably.
Now flight is there, sir, from Kurnool to Bangalore.
Oh, really?
Yeah, weekly
But
4 times.
Actually, the roads are so good. You will reach. Okay.
Yeah.
70-degree scope.
You
I
want to
think
have
we're
a look
already
again
into
at the
12
content?
o'clock.
Yes,
So
sir.
I will hand over the mic to Naveen. Now I'll just show you a final picture with a 70-degree.
Yes, sir.
Hopefully it was okay, JP. I think.
Sir, we must congratulate you for your nice demonstration. So the points that we have learned today is that, so the preparation of the patient preoperatively and during surgery, what precautions that we need to take, packing and air traumatic way of removing the bony lamella, and exposing
Yes.
all the cells step by step.
Yes.
Very nice. So if you can
Yes.
orient us again with the ball probe, that will be better.
Yes. Ball probe, finally long ball probe.
That's the frontal that we are looking into now. Yeah.
Frontal beak.
Yes, sir.
Posterior table.
Yes, sir.
See, this is a supraorbital cell here.
Yes, sir.
Anterior artery will be here. I have not gone there because it's hanging on a mesentery.
Okay.
Yeah, I don't want to die. This could be the anterethmoid here just behind this cell.
Yes, sir.
45-degree forceps. And then the posterior fovea.
Yes, sir.
And then the sphenoid also you can see.
Yes, very clear.
Yeah.
Maxillary, I think everything is clear now, sir.
Yes, yes, yes. Anyway, I'll ask Naveen to look up that as well.
Yeah.
Naveen is a fantastic endoscopic surgeon.
Oh, nice.
Yeah, yeah. He's a very good, you can see his endoscopic septoplasty. That is my anterior ethmoid artery, boss. Ball
Yes.
probe.
Can point with the ball probe so that will be better for us.
I will show you. This is the anterior ethmoid artery.
Yes.
This.
Okay.
This is a supraorbital cell, posterior
Yes.
border. This is just a cell below that. This is hanging on a mesentery.
Okay, sir.
This is making an angle of 45 degrees from back to front.
Okay.
Unmistakably is the anterior ethmoid artery. I don't want to unnecessarily play with it because this cell is nicely open.
Yes, sir.
Yeah. Thank you very much.
Thank you very much for your nice demonstration.
Thank
Big
you,
round of
thank you.
applause to you.
Thank you.
Thank you very much, Deepak.
Thank you, sir.
Thank you.
Put him on PIP initially. Akade FES ಮಾಡ್ಕೋಬೇಕಾದ್ರೆ. My audio off. Huh?
Thank you, Dr. Deepak. This is Dr. Anand Bhattacharya from Calcutta.
Now, on concluding the second session, I would like to thank our expert surgeon, Dr. Deepak Haldipur, sir, for this wonderful demonstration of the surgery. I would also like to thank our moderators who have joined us for this session, Dr. Sanjay Agarwal, Dr. Jaiprakash Reddy, and Dr. Harihar Murthy. Thank you all for this very informative session. Now, I would like to call upon Dr. Rajiv, sir, for his speech on post-operative care in endoscopic sinus surgery. Thank you.
Okay. Good morning, everyone. It was a very nice, excellent demonstration by Haldipur sir. And today we will just have a short bird's eye view about post-operative care for a patient who has undergone endoscopic sinus
Now
surgery.
the cartilage is stable.
Now, post-operative care is at least as critical as the surgery itself for the success of the surgery.
Level number 9.
And both the surgeon and the patient must be committed to do whatever is required to achieve a good result and pursue the appropriate post-operative care. The most common complication which the initial surgeon faces is that there is a failure to solve the problem for which the sinus surgery was performed. After functional endoscopic sinus surgery, the mucociliary function is impaired for approximately 6 weeks. According to healing is complete, there will be a lot of inflammatory changes occurring in the nasal cavity. Initially, there is a coagulation of the blood and other liquids which are there in the field of the surgery. And there will be some inflammation for 2 to 5 days. Within the first week, there is a tissue regeneration which starts. And the tissue regeneration is starting from around the 4th day and it continues for up to 6 months. And during this period, we can assist the healing of the sinus cavity with appropriate post-operative care. There are like thousands of articles and studies which have been performed on this topic. So it is very difficult for somebody to go through each and every article. Luckily, we have very good review articles and meta-analysis and other such studies which give us an overall view about the post-operative care. So this article, which is a very important article, and I've used this for the basis of this talk. Now, initially, the survey of about 859 otolaryngologists showed a wide subjective and non-evidence-based practice in the US. I think it's the same status in India. And a good review by Eloy et al. Showed that there is a lack of consensus in the necessity of post-operative care components such as debridement. If we go through the various components of post-operative care, the first one is the use of antibiotics for maintaining the sinus cavity post-operatively. There are several studies, and initially it was felt that antibiotics are very important, but many of the studies proved that antibiotics did not improve the outcome of FES and nor decrease the bacterial growth long term. In the early post-operative period, however, antibiotics have some role in the improved healing, the reducing the obstruction and crusting. There is no role for topical antibiotics after sinus surgery. In fact, one of the newer studies shows there is no difference between using antibiotics and herbal Chinese medicine, for which the mechanism of action is not known. So we can conclude that antibiotics have a role in the early post-operative period, but over a long period of time, it did not show any improvement, statistically significant improvement in the outcome of the patient. Initially, Stamberger, Kennedy, and others advocated aggressive debridement of the nasal cavity starting from the next post-operative day. However, in the 90s, there were some large RCTs which showed that there is a limited role for aggressive debridement, and outcomes are same after aggressive debridement and no debridement at all in the initial post-operative period. Comprehensive Cochrane review in 2018 concluded that there is uncertainty about the effects of debridement, and there is very low quality of evidence for debridement, and there is little or no difference in disease-related quality of life or disease severity, whether debridement is done or not. However, there is a improvement in the form of low risk of additions at 3 months follow-up if the debridement is done. Therefore, for the early post-operative period, especially in patients who have nasal polyposis, debridement leads to short-term improvements. Therefore, it has to be, it is an appropriate modality of management in the post-operative period for those with polyps. Those without polyps, there is no benefit of aggressive debridement in the post-operative period. The next component which we use is the perioperative steroids. Here, the perioperative steroids are definitively and conclusively shown to be useful in the perioperative period. And both animal studies as well as large-scale human studies have shown the benefit of perioperative corticosteroids. They reduce if given preoperatively, they reduce the blood loss, shorten the operative time, and they have a significant effect in reducing the risk of recurrence of nasal polyps. Their role is a little bit unclear in those without nasal polyps, and there is no evidence of increased risk of bacterial infection when steroids are given. And steroids have no detrimental effect on wound healing in the post-operative period. Therefore, conclusively, we can say that there is a good role for steroids perioperatively when we are doing endoscopic sinus surgery. About nasal irrigation, there are several studies done. There are two types of nasal irrigation solutions which are available. One is the high volume nasal irrigation. The second one is the low volume high pressure nasal irrigation. The high volume nasal irrigation with the use of compressible nasal douching devices, they work by pure mechanical rinsing and as well as dilution of the mucus and secretions, and they improve the mucociliary transport following surgery. Therefore, it is recommended that in the beginning, we should advise the patient to frequently rinse the nose with a high volume solution, and later on less frequently. And generally isotonic or slightly hypertonic solutions are preferable. There are several studies. I'll just highlight a few of them. Small RCT showed improved edema and healing following endoscopic sinus surgery. It's possibly because of the anti-inflammatory role of the sinus rinses. And there was also a study which showed marginal improvement with ringer lactate solution after endoscopic sinus surgery compared to use of saline. Okay, as I mentioned before, it is better to use a high volume, low pressure irrigation compared to a low volume, high pressure irrigation. Some surgeons advocate the use of steroids along with the irrigation solution. Okay. So nasal irrigation with steroid showed an improved airflow and reduced edema and crust formation. And it is safe in the postoperative management of patients with nasal polyposis. And there is a significant decrease in the recurrence, polyp recurrence. Therefore, you should consider using steroid along with the saline solution in the nasal irrigation. Topical nasal decongestants, there are mixed results. One of the studies showed that there is no evidence to use xylometazoline post-operatively, and there may be increased incidence of pain post-operatively if you use a nasal decongestant. However, in the early post-operative period, it may be useful to reduce the bleeding, crusting, and other similar symptoms, and also reducing the nasal resistance. Some countries routinely use hyaluronic acid in the form of a gel. It is applied on the surgical site. This reduces the adhesion rate, but the studies which are available are usually small in number. With the participants are small in number, and they require larger trials to promote this solution. Stents have been promoted as a solution to maintain the patency of the ostia following the surgery. It is still, we can call the status as a potential game changer in the postoperative care. They are used to separate the wound edges and reduce the blood collection, reduce the discomfort, and provide a matrix for epithelial migration. Stents also serve as an occlusive dressing and has a positive influence on wound healing, debridement, and mucus secretions. But the systematic review, which was done in 2015, concluded there is inadequate data. It is an emerging field in the postoperative care. Nasal packing. Most of us do nasal packing. There are few who say that there is no need of nasal packing. But small RCT in 2009 said that there is no significant benefit in using the carboxymethyl cellulose or Stamberger cyanofoam. So this was from the Graz University Medical School. And they said that there is no significant potential improvement using the cyanofoam compared to the other methods of nasal packing. However, the cyanofoam and other carboxymethyl cellulose packs can be a useful vehicle for extended drug delivery. So this has to be explored. There was also some discussion about use of airways through the nasal pack to produce, to improve the patient score post-operatively. There are small scale studies which have explored this possibility. Nasal packing with airway has excellent potential benefits such as ease of suctioning, oxygen supplementation, and hemostatic effects. So they should be considered, and we should have larger trials to improve. So the latest use of technology in postoperative care is the development of a multivariate logistic regression model, which will predict the likelihood of development of synechia postoperatively. So with the availability of such models, maybe we can consider more aggressive debridement and other techniques postoperatively to improve the patient outcomes. Thank you.
Thank you, Dr. Rajiv, sir. Now we shall move on to the third part of the session. I welcome Deepak Haldipur, sir, for joining us here. The third part is endoscopic septoplasty, headed by Dr. Naveen, sir, and the moderators are Dr. Srinivas V, Professor and HOD for BGS GIMS Bangalore, ex-professor and chairman, Department of ORL in RAK Medical Health Sciences University, Dubai. He has expertise in otology, ESS, and MLS. Special interest in OSA. We also have Dr. Manojendra Narayan Bhattacharya, has over 2 decades of experience. MBBS and post-graduation from University of Calcutta. He did his DOHNS from Royal College of Surgeons, England. His MRCS from Royal College of Surgeons, Edinburgh, and MRCS ENT head and neck surgery from Royal College of Surgeons. former consultant in the Department of ENT, Head and Neck Surgery at West Cross University Hospital, London. He was the faculty member for DOHNS, Royal College of Surgeons, consecutively for 5 years.
Leave the suture.
We also have Dr. Sonali Pandit. Ma'am, she is an ENT surgeon, scientist having wide experience and known for her research work on stem cell treatment for sensory neural hearing loss. ENT postgraduate, worked for 8 years in Australia and gained valuable surgical and research experience. Fellowship in Pediatric ENT from Sydney Children's Hospital. MS in Hearing Research from University of New South Wales, Australia. Her main areas of interest are otology, neurology, allergy, pediatric ENT, and voice and phonosurgery. She has been an active voice for the prevention of lifestyle diseases related to ENT issues and has been invited as guest faculty in various seminars and conferences. Over to OT.
Can I have the mic, please? Can I have the mic, please? Hello? Hello?
Hello.
Sir, Dr. Vishwas here.
Hello.
Sir, Dr. Vishwas here, sir.
Yes, sir. Dr. Deepak here, sir. Tell me, Vishwas, sir.
Sir,
I'm in the hall. Tell me. Yeah.
Yes, sir. Just to reiterate what I've done so far, I've
Yeah.
done the asymmetric osteotomy. So the
Yeah.
tilted bone has repositioned itself. I'll
Yeah.
just focus the camera, sir. Yeah.
Yeah.
So the bone which was tilted like this, because of
Yes.
the asymmetric osteotomy, it has repositioned itself like this.
Yes.
And then the medial and the percutaneous lateral osteotomy has made sure that the segment has gone in. So
Okay.
now the bony septum has also straightened up
Yes.
and has carried the K area along with it. The partial
Yes.
cartilage what we had left behind, it has carried it. And septum also I have straightened it by placing perforated ethmoidal plates. I'll just show the lid retractor, please. And now I'm trying to place it back beside the cartilage envelope we had. Can you see this?
आज आपको अपॉइंटमेंट चाहिए तो 3 बजे के आसपास मिलेगा, 2:45-3 के आसपास.
This is the cartilage was remnant behind, and I'll be attaching the septum to the same cartilage. Once this sits on the maxillary spine. Now I'll be tightening the maxillary spine here, so it sits strongly here
The
on
picture.
that.
Yeah. Okay.
And then I will be getting this in alignment along with that.
Yeah.
piece.
Now the septum looks good, Vishwa. Beginning it was looking horrible.
Yes,
I
sir.
don't know how you elevated this. This, it was so thin. You took it out and straightened it and put it back. Is it?
Yes, sir.
Yeah.
Same
Good.
partial extracorporeal
You
septoplasty.
take the picture a little upwards. We are getting it in the bottom of the screen now.
I'm sorry, sir.
You've done all the hard work. Now it's better.
Yes, sir. So
yeah, correct.
once this sits on the spine, this will
Yeah, yeah.
automatically come into alignment, sir.
This looks good. It
Yes,
was
sir.
a very bad septum. I really appreciate that you took this up for demonstration. And even the planes initially, the tissues were all attached to this. Probably a traumatic nose, I don't know. But you have done a fabulous job. Go ahead, Vishwas.
Sir, one more thing, sir.
Yeah.
So now, fifth size, last size. Yeah. Yeah.
Vishwas.
So, yes, sir. So the
Dr.
airway is
Srinivas
quite
here.
clear now, with all the spur and the bony septum also being corrected. Posteriorly,
yeah.
also there was a deviation which had to be corrected. Now I've taken the stitch on the maxillary spine, and now I'm attaching the cartilage to it so that it comes into alignment, sir.
You drilled the holes in the maxillary spine to take this stitch?
No, sir. I took a 3-0 proline round body and
Okay.
went through that small cartilage periosteum perichondrial envelope to take the stitch. It is good enough, sir. Drilling is
Okay.
required only if it is bare bone. Then
Okay.
I do the drilling, sir.
The reinforcement you are given to the anterior septum, it's a bony or it is cartilaginous?
Bony and cartilaginous, sir. So the fracture points, I'll just show you, sir. The fracture points, hold it, please. Hold the lead retractor correctly. The fracture points that I pushed the perforated ethmoid. I can just show it in a while. I'll just bring it out and show it, sir.
No, it's okay. It's okay. Yeah. No, we missed this portion. That's why.
It's a little tough to bring it out. That's why.
Okay.
So this is the portion, sir.
Okay. Okay.
So that's the ethmoidal plate that you can see there in position.
And Vishwa,
Yes, sir.
thanks to the organization capabilities of Chetan and you, so many medical colleges are logged in simultaneously. And there are about 11 places or 12 places, 15 places where this is going on live also.
Yes, sir.
In Kolkata, the Taranjan National Cancer ENT Center, Dr. Soumya Deepta Ray. Pune, D.Y. Patil Medical College, Dr. Girija Ghate. In Gujarat, it is the SMS Hospital, Dr. Viral Prajapati. Hubli, KIMS, our Dr. Naveen's professor and HOD, Dr. Ravindra Gadag. He is sitting there to watch Naveen's endoscopic septoplasty now with all his PGs. Delhi RML Hospital, Dr. Ashok Kumar. Mumbai, D.Y. Patil Medical College, Nerul, my close friend, Dr. Yogesh Dhabholkar. Mumbai LTGM Hospital, Sion. I think this is a feather in your cap, Vishwa, and even our Naveen, that Dr. Renuka Bradu is watching you there. Orissa, KIMS, Dr. KK Samantre. Ghaziabad, Santosh Hospital, Dr. Sushil Gaur. Delhi, Safdarjung Hospital, Dr. Neena Chaudhary. Bangalore, KIMS Hospital, Dr. Jagannath, a very eminent otology surgeon who does a very good job. MS Ramaya, Dr. Chandra Kiran, another very good endoscopic surgeon. Lucknow KGMU, Dr. Anupam Mishra. And Hyderabad KIMS, Dr. S.V. Ramana. I would again like to thank Alkem and Rajarajeshwari Medical College for tremendous support. And I think this September, once I see now, Vishwa, I think we should send Akhilesh Yadav to you. I think we will hand over the mic to Naveen now. You be on PIP. Okay, Naveen, you can start. As they say, your time starts now.
Thank you, sir.
Hello, good afternoon, Naveen. Dr. Srinivas here.
Good afternoon, sir.
I'm in PIP.
Yeah. We are ready to see
Talk
your
to you.
show.
Thank you, sir.
Good afternoon, Naveen. This is Dr. M.N. Bhattacharya from Calcutta.
Good afternoon, sir.
Good morning. Good afternoon, Dr.
Good
Naveen.
afternoon, madam.
Dr. Sonali
afternoon.
Pandit from Mumbai. Dr. Deepak, sir, good afternoon to you too. And Dr. Vishwas.
Good morning, madam. Good afternoon. Good afternoon, Dr. Sonali.
Thank you
Good
so
afternoon,
much.
madam.
Thank
Yeah.
you.
Good afternoon, Dr. Halipur.
I'm
Bhattacharya Saab.
that all the stalwarts are watching, and after Deepak sir and who's the Dronacharya who had been operating till now, and our Jakanacharya who is operating on the other side.
Yeah.
It's a tremendous responsibility on my shoulders now to carry forward the same.
It's always said that the master comes at the end.
Absolutely. I totally agree with you, sir.
And at the outset, I thank the management of Rajarajeshwari Medical College, Department of ENT, Rajarajeshwari Medical College for this opportunity. And I am immensely grateful to my teachers from KIMS Hubli, my alma mater, Dr. Ravindra Gadak sir, Dr. Umesh Naglotimat, Dr. Vikram Bhatt, Dr. Somnath, and my teacher, my friend, Dr. Manjunath. They've been all kind and been guiding force for me. And not to forget my mentor and my guide, Dr. Deepak Haldipur. He has been the driving force of my life. So I've already infiltrated the septum, and the inferior turbinate has been lateralized on the left side, as we see. And I've infiltrated the septum on both the sides, and good amount of decongestion has happened. And in the meantime, I lateralized and outfractured the inferior turbinate on the right side as well. So before that,
you could hardly visualize the middle turbinate. So this is the septal spur which we see.
Yeah.
Now coming to the endoscopic septoplasty per se, compared to a headlight or an external septoplasty, there are advantages. So here we have a proper visualization, and precisely, what are you looking at? In a headlight, it's very difficult. So beyond the probably halfway through, everything is by tactile sensation. But here with an endoscope, we precisely can appreciate till the sphenoid and the high DNS and the posterior part of the spur. So everything is visualized with an endoscope. And once we start elevating, we realize entering the plane is so very important, and endoscope makes a huge difference. So now the indications for us could be either the functional, that is for the nasal obstruction. And apart from that, it could be also used for as an approach for endoscopic for sinus surgery. Now, the problem is here, if we have to do a endoscope FES on the right side, so because you have a high DNS and a spur here, with great difficulty you may manage to do a sinus surgery here, but repeated instrumentation will lead to raw surfaces on either side, and later post-operatively, which will lead to synechiae, which we don't want to happen. And endoscopic septoplasty per se is tailor-made to the situation. That is, there is no set rules as to you have to do only this, you have to go step by step. So depending on the situation, you're going to be tailor-made approach. So I usually take the incision on the left side and kind of a modified Killian's incision itself, just posterior to the mucocutaneous junction, and the incision should go from superior to inferior all along till the floor. And once our incision is till the floor, it's very easy to address the maxillary crest issues. Here in this particular case, the maxillary crest, as we saw on the CT scan, is hardly giving much of a problem to us. And I initially use our blunt end of a suction to get into the plane.
Dr. Naveen.
Yes, sir.
This septoplast endoscopic.
Yes, sir.
We usually do it along with the FES. If there is no FES indication, just septoplasty.
Yes, sir. Okay.
What would you prefer?
So I didn't get your point. No. Sorry.
He said if there is no need for FES and you're doing only a DNS,
okay,
would you still do an endoscopic septoplasty?
No indication of FES, but still?
No. If the patient requires only a septal correction,
okay,
and no FES,
okay,
would you still do septoplasty endoscopically or with the headlight?
Yeah, endoscopically, sir.
I know that you converted me only.
So the advantages of endoscopy, that's what I was telling. So compared to a headlight, so the visualization per se and the structures which you visualize is so precise that you prefer an endoscope over a headlight. So here we are entering the plane.
This is one point for the postgraduate. See, the first 2 millimeters of elevation, he is making sure that he is seeing the cartilage clearly. Septal elevation or a Haddad flap elevation is only that. See, this portion, if you elevate very clearly in the right plane, then further elevation becomes child's play. you need to get into the avascular plane. The need to do an endoscopic septoplasty is because a very good teaching tool as well.
Yes.
Because when we were learning septoplasty, we had to stand behind the surgeon. Fortunately, most of them were short. Otherwise, you can't see anything.
Yes.
I completely
So-
agree with you, Haldipur sir, because this is the great way to teach the junior colleagues. Otherwise, it's very difficult. You only come to know when the septal cartilage comes out or some part of bone comes out. Otherwise, what the surgeon is doing inside, it's very difficult to see as a junior resident or when you're learning. So this is a great way to demonstrate to junior colleagues, even to the nursing staff. They know what's going on and they
Very
assist
true.
you well. Yeah.
And I want the audience to appreciate he's not pushing the instrument through. He's gently caressing in that area and moving, making a slight lateral movement. And he's already gone halfway. Another
And this
few
is
seconds, he'll be near the
very,
rostrum
very
of the
wonderful
sphenoid.
instrument, the Cartels elevator, which I prefer compared to Freer's elevator. It has optimum sharpness, optimum blunt, and a very good shape, as you see. And this is very precise. You can see how we can go and create an inferior tunnel as well.
Feel it laterally. Don't
And
push it. Push the instrument. Don't push the instrument. You have to peel it up.
yes,
And what's your take on suction elevators?
see, I would prefer it if there is a lot of bleeding. But in this particular case, the only thing which I not very satisfied with the suction elevator is basically with respect to the shape and the size of it. So I do prefer whenever there is some amount of bleeding.
Okay.
But most often I prefer to use Bartels elevator.
Under the
Suction elevator
suction
is
happens
much more
when you're using
blunt.
suction thing, the whole flap tries to collapse. Flap
Yes.
tries to collapse.
Yes, especially
Yeah,
when there is a
suction
lot of
force.
bleeding aspect.
Yeah.
And most of the time the suction works better when you don't want it to work.
Absolutely.
And
the
the
suction
septal flaps,
elevator is much
The
more
cautery and
blunt.
suction never work when we want them to work. But again, you can appreciate the wonderful field given by the anesthesia
Yes,
department.
yes.
Dr.
Really grateful to them.
Rangalakshmi
What
and
a
team.
field.
I think if they can keep the heart rate at 57 or 60, the way they did, if they're doing it in every case, I think the ENT surgeons would be really eternally grateful. Yeah.
Yeah, even now the heart rate is 73, though my heart rate is around 100.
For the postgraduates, this is what you have to be very meticulous, slow. Take your time to elevate. Take your time. Don't
Yes.
hurry to go into the other place or try to remove it. First, try to elevate all over, behind, front, back, and everything, so that you'll have a good plane. You can see everything now. He's almost gone to the rostrum of the sphenoid, so he's exposed everything. Now you can proceed with your opposite side, going into the opposite side and bringing
Yeah.
out the septum and all doing all those things.
Now this is our quadrangular cartilage.
And my heart rate was around 140 in my first demonstration in Amravati. So don't worry, you are still 40 to go.
Perpendicular plate of the ethmoid. And as we go posteriorly, we approach
See
the
the ostium also. You
rostrum.
can see the ostium almost.
And yes. So we can see the sphenoid sinus here now.
Yes.
Yeah, that is the thing. Yeah, you're onto the sphenoid.
Yes, yes. And now the incision on the cartilage as well, and the amount of cartilage to be removed, it's all tailor-made. So rather than calling it a septoplasty, it's preferable probably to call it as a septal correction. So to prevent any kind of a saddle nose or columella retraction, we have to preserve at least 1 to 1.5 centimeters of cartilage along the dorsum and 1 to 1.5 centimeters of cartilage along the caudal strut. So we have seen in many surgeries like skull base, either for a pituitary or a tumor, that we do literally a posterior septectomy. So keeping in principle of maintaining the caudal and dorsal strut, even if the entire septum is removed, you don't find people coming with either a saddle nose or a columellar retraction. So as far as possible, in routine cases when you're doing a septoplasty, be, as Dr. Surginova sir was saying, so be very meticulous while elevating. So when you have kept the entire flap intact on one side first, now you're safe. You can work
Even
on
if
the
there is a small tear
cartilage
opposite side,
and the bone.
now this will take care.
Yeah. So you're bound to be lucky that you'll not have a septal perforation at least.
Yeah, yeah. You rightly said that now that it has to be changed into not a septoplasty. My list always now in my department, it always carries it as septal reconstruction. We
Right.
don't put it as septoplasty, we put it as septal reconstruction.
Yes, sir.
So,
Naveen,
Yes, sir.
maybe you did the white balance in the beginning. Otherwise, you do a white balance once, Naveen. That stars fellow, ask him to just check and do the white balance once.
Okay, okay, yeah.
Done?
Yes, sir. Done.
Yeah. Now check out, maybe you'll get a better picture.
Yeah, very true.
Dr. Naveen.
Yes, madam.
How would you tackle anterior septal deviations with endoscopic septoplasty? Do you use like a headlight first to take, like if you want to take hemitransfixation incision, if you want to deal with caudal dislocations, how would your approach change?
If there is quite a bad caudal dislocation, endoscopic septoplasty per se is not the answer for that. We prefer a headlight or external septoplasty for that. At least till we get a proper plane.
Yes.
It's very difficult if you have a severe caudal dislocation to get a proper plane. Endoscopic septoplasty has its limitations. Though with a great struggle, we can still manage to elevate. But with a headlight, it's much more easier.
Yes.
Madam, there are so many patients who have a caudal dislocation coming all the way up to the antermost limit. Even before you put the endoscope, you can see the deviation.
Yes.
In that, there's no point in struggling with the endoscope.
Yeah.
Better to go with the headlight and to go with the hemitransfixion incision.
Yes.
Or what Vishwas showed today.
Yeah.
And correct it, because many of them don't come with nasal obstruction.
Yes.
But they're concerned about that cosmetic dislocation.
Yes.
And unless you correct it, they will not be happy. And that part is something they can appreciate standing in front of the mirror. So it's better to use a headlight, madam. In that, I think we won't advise things to be done endoscope.
Or maybe combined approach.
Yeah, whatever.
And one more point which I would like to make is the purpose of endoscopic septoplasty is basically to give a functionally breathing nose, in the sense for the nasal obstruction. So for that, we need to understand the concept of the nasal airway path, or the what we call as the eddy currents. So the air blast hits the anterior end of the inferior turbinate and it moves up towards the lateral wall like this, towards the middle meatus, and going towards the posterior end of the inferior turbinate and into the corona. So the purpose of septoplasty here is not to give a perfectly straight septum. If we are able to appreciate the middle turbinate and middle meatus, see now here we are hardly able to see anything. So the cause for the nasal obstruction on the right side is because of the high DNS. And here it was basically because of the polyps, the patient had an obstruction on the left side. So for very high DNS, if we are able to give a straight septum at least till the middle meatus, that is enough. If, for example, the higher end is very much deviated towards the lateral wall, we have to do a kind of a septorhinoplasty where the upper lateral cartilage is taken care of. With an endoscopic septoplasty, we cannot address the very high DNS, and it is really not required as far as nasal obstruction is concerned. If the middle meatus is clear, that should suffice the purpose.
Yeah, in fact, this is something, when we were postgraduates, we focused more on the, spur in the floor and more towards the inferior meatus. We have realized that the air current hits the anterior end of the inferior turbinate and goes into the middle meatus. So it is really not required to correct the attachment of the upper lateral cartilage in every patient who has nasal obstruction.
And as we see here, anteriorly
would be the answer, yes.
Sorry, sir. Sorry to interrupt.
In majority
anteriorly,
of the
we
people,
see the cartilage is quite straight enough.
Yes.
So we are at liberty to preserve quite a bit of the caudal strut. And as we go inferior,
yes,
go towards the nasal floor.
Yes.
And again, the incision should be partial. So don't make a through and through incision. Again, I use my cottles to deepen the incision. The blunt end of the cottles is a safe instrument again, so that it doesn't cause a tear on the opposite flap. So here we see the opposite flap is intact. And this is what I want you to appreciate with an endoscope. Opposite side as well, we are entering into the avascular plane.
Naveen.
Yes, sir.
Pardon me if I'm wrong. After the first step, I usually have changed to I dislocate the cartilage in the bone first.
Okay.
Cartilage in the bone I dislocate. I'll
Okay.
do the bone work and
Okay.
come back anteriorly and do the cartilage work. Well, but the opposite side I don't elevate at all. I remove a strip of cartilage
right
directly in the floor, and also whatever is necessary in the posteriorly if it is coming, and keep maximum cartilage intact.
Yeah, here also, sir, we are going to keep the maximum.
Your suturing the cartilage and bringing it to the center. That's what I do. I usually go through first I dislocate the things. I don't know, I'm wrong or right like this.
No, there's nothing wrong or right about it.
But that is the method I use. I go through the bony cartilaginous junction. I elevate it out on the periosteum. I don't elevate the perichondrium at all initially. I on the opposite side. But periosteum both sides and deal with the bony thing first, and then come back and look into the anterior things and do proper limited corrections where all it is necessary.
So now
I think your point is well taken, Srinivas. The only problem is many times on paper this looks very good, but in my experience sometimes I've had people coming back with deviations. Probably the answer to this is maybe we address the upper part of it also, because the
you don't look there, you hold here. Okay,
even this cross hatching doesn't help.
Yes.
Only alar batten grafts help. So that's why we remove more amount of cartilage. But if you can accomplish it well, what you are saying is the best. No doubt at all. No doubt at all. It's like putting a vein graft in a stapes surgery. It is little more cumbersome to do it. That's about it. Yeah.
Srinivas sir, can I add a thing about what I'm doing here, sir?
Go ahead. Go ahead.
Sir, I've just done a transdermal stitch here to get the tip point. Okay. And then I'm suturing in between the medial crura. This is one point I want to bring to the notice of the people watching today. Now, generally what is done is there is some concept called as columella strut to make the anterior part stable so that there's no retraction. And the septum, when we take a stitch through the medial crura, septum has to be behind it. We should not take the stitch through the septum. The reason being, it is not a single structure. If we can actually feel in our own noses, the medial crura moves independent of the septum. And this is how we have to suture it back. Many places, the cartilage, septum, and this is sutured together. Then the patient says that my nose is woody and hard and doesn't move at all like earlier. So this is one step I just wanted to mention, sir. And the rest of it is anyway corrected, and I'm going to close the incisions now.
You have done a superb job, Vishwas. We would like to
Yes, sir.
applaud you for this, because in the beginning, it was simply looking horrible. But you have taken your time and you have done justice. ALR symmetry has come back beautifully. We can see the septum is so straight. Superb job, Vishwas.
Thank you, sir. Thank you so much, sir.
Really, we will get the myelination of your sciatic nerve measured, because to take up this case for a demo requires a lot of guts. Maybe we'll do a nerve conduction study.
Thank you, sir. Thank you so much.
Did you have a choice, Vishwas?
Sir, I don't
You have a choice about the case.
Fortunately, the Rajashri team had listed 3 patients, sir, and this was the first patient we had, and we took him up. So I didn't choose between them, but then what came my way, I tried to take it, sir. I hope I've done a decent job. Section.
Vishwas, Hari
Yes.
here. Great job, man.
Thank you so much, sir.
I just wanted to ask you a question. Are you going to put one more stitch closer to the tip?
Yes, sir. One tip graft over there, sir. The reason is he's got a reasonable projection, but he still needs a little bit of enhancement, a very small one, sir.
Would you stack any cartridge up there?
Cap graft, sir, I might not, but I will see the tip graft position, and then if I require, I'll stack it up, sir.
Okay, thank you.
Thank you, sir.
Dr. Vishwas.
Yes, sir.
Last thing. So
Yes,
you have not
sir.
put the columella strut.
I will be putting next, sir. So that
Next
is
thing.
an independent cartilage.
The pocket is there.
Yes, sir. The pocket is still here. That's an
Okay.
independent cartilage. What
Okay.
many times happens is when the medial crura is sutured,
Yeah.
we suture the cartilage also into the septal cartilage, and that becomes a problem many times.
Okay, okay. So we're going to put separately the strut.
Yes, sir.
Okay.
We'll move it to Naveen now.
Yes, sir.
And
Sure,
you come
sir.
back again. Yeah.
Yes, sir.
While on the subject of the septum that Dr. Naveen is doing, like Dr. Srinivas said, I also do a bony cartilaginous dislocation first, right around, which means along the floor posteriorly and a little bit superiorly also. That gives a better handling of the septum, which is intact. So you have a lot more of the septum which has not been cut, you see. So one of the things that I have been routinely doing is making sure that I don't do the cross hatching partially. Full thickness of the cartilage is cut so that you have a tiling done of the cartilage. So it gives a lot more flexibility to the cartilage, number one. Second thing, in a case of very severe deviation, that may not be sufficient because even that keeps the cartilage curved the way it was earlier. The memory may have been broken but not lost. As a result, what I do is I remove a sliver of cartilage all around of about 1 millimeter, as a result giving it a free play. And then the septum which is remaining now, the bony septum, we can sculpt it, straighten it, and make perforations like what Vishwas did. And that's what I do in those kind of cases, so that you are supporting it again and making sure it stays in the midline. Of course, the prerequisite for this is that the superior deviation, the perpendicular plate, if it is severely deviated, it has to be addressed adequately, as you can see over here. So
Yes.
that can all be done. I prefer to do it the way Srinivas has mentioned earlier. So we go ahead and do that, and then we come back and do it. The thing here is to cut it with a proper scissor.
Yes.
Never
And
use any
this-
instrument and twist it.
For me, the reason I prefer this cartilage window which I have created,
Yeah.
it gives me wide access and visualization.
Yeah, there are many ways to skin a cat. Yeah,
Yes.
whatever works for you, you have to do.
Yes, yes.
And see, Srinivas is a genius. We have to show the techniques which helps common surgeons.
And now, just cut the
For the postgraduates, as you go superiorly, don't use your Lux forceps or your Blakeslee forceps to twist and twirl and remove it. What he is doing is the perfect thing. You have to make 2 cuts, and in between the bones become free, and you just pull it out. Okay.
So now once,
never
as sir
do
said,
that.
once you have made a cut here,
Yes. See, that is how you have to remove the bony thing. Even bony thing, you can use your tough turbinectomy scissors also. If it is not cutting through your endoscopic scissors, use your turbinectomy scissors and cut it, or septal scissors. There are so many available, like serrated and all those things. So use that and then cut it out, and then see that you get a neat cut edge, not irregular edges. And one more thing is, perpendicular plate is loosely hanging from the cribriform plate. So better not to avulse it, okay, and cause complications like CSF leaking and all those things. Yeah. So you have to always, especially dealing with high DNS, when there is perpendicular plate is so much deviated, you have to measure and cut, so that not initially only, cut a few millimeter, then go up a few millimeter, and millimeter by millimeter you can cut and remove the pieces.
Yes.
It's always better to it.
Yeah. So as sir was saying,
very good elevation, Naveen.
Thank you, sir. So this is what we were speaking about. So now you can appreciate the middle turbinate.
Wonderful.
In case the deviation has not been addressed enough. For example, you have gone, so we could here visualize to what extent we are going to cut. So as I was saying, we are going to go millimeter by millimeter. You still can take out a bit of cartilage or bone, but here it is not required. But
better to undercorrect initially,
yes,
rather than repent by taking out a bigger chunk.
Yes.
Yeah, and now you can even move the middle turbinate and make the space in the middle meatus.
Yeah.
Because the middle turbinate was pushed laterally by this high deviation.
So now we need to address the bony spur.
You can see as a teaching tool, it is so convenient.
So here again, I prefer the Cottle's elevator.
So Naveen, what is your advice? Novice postgraduate, should they start with endoscopic only and learn this one only nowadays, or you have to go for this?
I would, yes, sir. I would advise to do endoscopic, but
straight away learn endoscopic.
So once they are well versed with routine diagnostic endoscopy, see, headlight endoscopy also, I'm not denying it, sir. But at the same time, because as we were rightly speaking
what I
about,
prefer them to learn is, first thing, learn the incisions and initial elevations with the headlight. Till they get that acquaintance of reaching the cartilage, identifying the cartilage. Because with the headlight, cartilage looks better, whitish.
No, but the entire visualization, sir, may not be, see, in the sense they get used to visualizing the structures well with the endoscope.
Our moderator made a point, and that is in real anterior dislocations, we have to anyway use the headlight. So it is better they're used to both. Eventually, as they become more comfortable, they will move to endoscopy. I still remember when Naveen joined me, though I had done endoscopic surgery for 15, 16 years, I was doing septoplasty with headlight only. And once Naveen convinced me that endoscopy is the way to go, I started and now got totally used to it. So especially
now,
the younger
what I
people,
do for this spur is
technology
again
is like
make a
mobile
sharp
phone.
cut here.
Yes.
What was?
It's always better to create a scissor fracture line and then avulse.
Yeah.
Yes.
Srinivas made a very, very valid point.
Yeah. So
It
just
saves us
sir,
from-
how we should know how Caldwell approach as well. Even today, it's you need it many a times. So this is how like you should know
Great
both
grasp.
endoscopic and the conventional septoplasty approach.
And here you can see a small strut of cartilage. I prefer that to be there. It's going to prevent any kind of a tear on the flaps. So once I have created a fracture here,
Frontly, push it and make a fracture, yes.
push it away.
Fractures by itself.
Yes,
So there will be no tear at the spur.
yes. As far as possible, we can avoid. since we have already elevated the flap on this side, you have the leverage of this space here. So slowly keeping the cartilage there. So this is the cartilage which I was speaking about. You can slowly elevate. And the spur is out. Bottles. Now we can take out this cartilaginous portion.
Yeah, Naveen, we are on. Power is on.
So this cartilage, I prefer to be there and I take it out at the end.
Yeah, it's fantastic. Fantastic. Yes. This is the spot where we usually try to tear.
Yes.
Yeah. Yes.
Straight transfer.
No, for if the maxillary crest, Naveen,
sir,
you still use the gouge or you just pluck it out with lux or forceps?
I would prefer a gouge, sir.
Yes. Can you just push it out and fracture it? I've done many times. If you push it out to one side with little bit strength, so that it fractures.
It all basically depends on the bone. Some people who have this osteoporosis, they're very thin crest, which can be nicely manipulated with yeah. So it all depends. In real strong ones, you need to use the gouge.
So now we see the high deviation. This was the place of the spur.
And look at the turbinate also rolled over a little bit.
And the mucosa is in, mucosal flap is intact.
Yes.
Fantastic. Very nice.
And again, instrumentation, sir. For me, the selection of the gouge, I feel it's very, very important. So this bayonet shaped gouge, which engages, this gives a perfect leverage here.
Prefer U tip or V tip?
Sorry?
You
It's a V.
V tip or U tip? This is V tip. Yeah.
V, sir.
Yeah, V. There's one more U tip comes.
Yes, yes.
This is
But this engages perfectly here.
Yeah, that engages perfectly. Yeah.
You use this fishtail gouge in every case?
No, slow. Bottles.
Whole thing came out. At this point of time, I usually experience some kind of bleeding.
Yes.
Yes, from that canal.
Yes, yes.
From the
We have,
canal.
we have encountered many times, sir.
Yeah,
and
with the
again,
canal.
with pressure for about a
Yes.
few minutes,
Yeah.
there will be a brisk bleeding through the bone.
Yeah, that is anterior canal you get. I don't
Yes.
remember that canal. There's some canal coming there. So which
Yeah.
contains a small artery there, which bleeds. That's why
We have been
usually
lucky
what I
enough
do
that
is,
we didn't encounter it.
yeah, initially what I do is I cauterize the whole thing.
Yes.
I use before gouging, I cauterize it.
Okay.
I cauterize the thing, the whole bone. and cauterize bilaterally, hold it with bipolar, cauterize it till the down, till the floor, and then give a cut.
At times I have encountered this bleeding after pushing out the maxillary
Yeah, yeah,
crest. And then either if it doesn't subside with pressure, I do
Cautery.
have a ballpoint cautery where we cauterize the base here, sir.
Yeah.
There are three ways of tackling that bleed. Number one, sometimes a monopolar cautery. Number two, bone wax.
Bone wax.
Number three, you can use a small diamond burr and diamond.
And now,
as Deepak was telling, I was just having this thing about using burr for this removal of crest. Burring
yes,
it
we
out.
can do it, sir.
Yeah,
Just
burring
like we
out
do
would
it in our
be-
mastoids.
Yeah, like that.
Yeah, a
What
diamond
I
burr.
prefer is put a long Killian's blade
Yeah.
and ask some assistant to hold it, and then with endoscope in your hand and the burr, you can, I think so, we can start doing the drilling of that maxillary crest instead of gouging it out.
Right. So here I want some postgraduates to notice here, because the deviated cartilage portion was not much of a problem. So if there is quite a bad septal cartilage deviation, after we take an incision, we see the spring action is released. So there'll be overriding of cartilage. We have seen many times the cartilage will be overriding here. So at that time, I would take a small incision here and just make a small window here so that the cartilage fits properly. Here, this is
Yeah,
fitting
that's
properly.
a very good point. That's a very good point. Otherwise, it will spring back.
Here, it is sitting perfectly in place. So here, I don't need to do that.
But again, no harm in removing a millimeter also.
Yeah.
Because sometimes during healing,
Yes.
again, some shrinking, it will bounce back. Having shown this, take off a small V. What is wrong in it? You have done a beautiful job anyway.
What about the external figure of 8 suturing to this and
Yes.
pulling it down to one side?
Yeah. So just get a knife. So small sliver of cartilage. Yes.
I mean, to use sutures to just anchor it down in the midline,
Yes, sir. Yes, sir.
figure of 8 and all, yeah.
Quarters. So now post-operatively also, because you don't have any mucosal tears, the healing is good. And once there are no raw surfaces on simultaneous areas here, there is no chance of synechiae.
Dr. Naveen,
Yes,
have
madam.
you ever used endoscope holder for using endoscopic septoplasty?
I've never tried it, but rather I would feel, madam, compared to an ear surgery, for an endoscopic septoplasty, our movements with the scope
Are more.
are more.
Yeah.
So probably an endo holder may not be a good idea for this, I feel.
Yeah, there are some people who use it.
Madam, I think if they're used to it, it can also give good results.
Yeah. So it gives-
Neurosurgeons do it.
Yes.
It's a matter of getting used to it.
Yes.
And especially if you're planning to do a three-handed technique and things like that,
Yes.
endo holder is
That
also a
was
good idea. Again, you have to get used to using it.
That's correct, sir.
Yes.
So once in a while, we need to keep cleaning the scope. So once we have made sure that there is no bleeding, so now I would prefer to suture it. So either we can take a suture on the cartilage and anchor it.
Yeah.
Or we can go through the
Yes.
flaps.
See, in some cases where I've encountered a lot of bleeding because of this during septoplasty,
Okay.
I've used even Surgicel to be placed between the flap. Surgicel lined from top to bottom like a thin blanket and suture it up.
Bottles.
It has given a good results, like with bleeding.
Do you want to put the cartilage which you have removed, put it back? Naveen?
Sir?
Do you want to put you removed a good amount of cartilage? Do you want to put it back to prevent the flapping of the septum?
So really not necessary. It's like a extracorporeal septoplasty. Now here, as we said, so more than 1.5 centimeter, 2 centimeter of cartilage, which is there on the dorsum and along the caudal strap. Now it's really not necessary, or we can still go ahead and keep the cartilage back. But this is going to have a good stability without causing a saddle nose or a columellar retraction. And especially if while elevating the flaps, I encounter a tear. Get the cartilage. Forceps. Straight grasp. If there is a tear in the flap, then I would replace the cartilage and then suture along with it. But here, since the flaps are intact and there is a good dorsal and caudal support, there's no need to replace the cartilage.
And fortunately, because others don't have endoscopes, they can't go in and see the posterior perforation. Just a joke apart, but you can always replace it. But I think, Naveen, the best step was the way you keep that small sliver of cartilage in the maximum convexity of the spur.
Yes, sir.
And take it out last. That is why you don't get tears in the mucosa.
Get a sponge.
I mean, what suture material you're using and what number?
Sir, this is Vicryl.
Yeah.
Get the flap.
30.
30 Vicryl.
Okay.
Sir, I prefer this compared to a routine Vicryl because if you see the needle, it's quite wide.
Yeah.
In a routine 30 Vicryl, the curvature of the needle, here
It's
the
too
radius is much
Yes.
bigger.
Yeah.
It's 30 rapid which we use.
It's quite sharp also, right?
Yes.
This is the best part of endoscopic septoplasty, where suturing will become so precise other than your headlight one.
Yes. And I used a small bit of Mirocell here.
Yeah.
Bottles.
That's a good idea. Not to poke into lateral wall.
Yes. And we can precisely see the upper end.
Yeah.
Now, if you don't keep it here, probably will be blindly, as you said, sir, will be
Yes.
poking the lateral wall.
Yeah. And unnecessarily causing some bleeding there.
Yes.
That step which he showed very clearly, as he goes through, sometimes this sharp end gets into the inferior turbinate which you can visualize, gently push it back, just enough for you to hold the tip and bring it out of the nostril. If you are rough in that step, you can create a linear tear in the inferior turbinate, and that can start bleeding in the end.
One other thing that you can do possibly is to slightly straighten the rear portion of your needle so that you make it a J instead of a U or a curve.
And
like a C.
one more thing, sir. This is the way I hold the suture, the needle.
Yeah.
Okay. So instead of the routine way
Holding it
which we hold,
crossways, instead of holding it crossways like you usually
Yes.
would for a skin.
so this gives a better grip and you can anchor it very well.
Besides, Naveen, one other way is when you take the needle out from
Yes,
the
sir.
opposite side, one thing that I also do is to avoid the lateral injury, to take the needle inside the nasal cavity and then bring it out. Because once it has come out and the thread is free in the opposite side, then you can bring it out very easily.
Okay, sir,
Especially in
okay.
the deeper areas when you're doing the suturing, like when you're suturing the turbinate and all that to the septum, I take the needle backwards, posteriorly.
Okay.
And then I bring it forward once the free thread has come, free vicryl or thread which you're using has come into the opposite side. That way, there's very little chance of puncturing the opposite side. Especially
sir,
so
right.
after we have done a fess, we can push that needle into the orbit if you're a little
Yes, sir, yes, right, right.
energetic.
Suction. Sponge.
Naveen,
Yes, sir.
we'll just go to Vishwa and come back to you. Vishwa?
Yeah.
Ask Prashant to shift the audio to Vishwa, because we can see the final finish is looking very good there as well. It was a real tough case. Initially I was apprehensive. Vishwa?
Yes, sir.
Wonderful job, man.
Thank you, sir.
The
Thank you
nose
so
looks very good.
I'll
You
just
can
squeeze out the
yeah.
edema and show, sir.
That is one thing, and show us the nasal pyriform apertures also.
Yes, sir.
Because Dr. Nagaraja said no food till we see the final shape of the nose. And Chetan
Wet
also
gauze,
is
please.
agreed that till you finish the course, you can't go for food. So
Wet gauze, please.
White balance. White balance.
One more.
White balance.
One more wet gauze, please. So during closure, there was one point I just wanted to mention, sir.
Go ahead, Vishwas.
This stitch here, can it be seen? Can you focus on the stitches, please? Give a saline wash there. Here. Thank you. No, you need to show from here. So fold it down and go down on it.
and tell that person who is handling the VTOM to show the patient's nose only.
Yes,
He's
sir.
moved it so much. Okay.
Fix it. Just a minute, sir.
Yeah.
Okay. Won't turn, no? It's turning too much. Yeah, just hold like that and focus it. I'll just focus it. Sir, I just want to show the stitch here.
Yeah.
The V stitch has to be always a vertical mattress. It should never cross over the bridge because that will show
Okay.
the prominence. The rest of it can actually be a simple interrupted stitch. And these
Okay.
corner stitches should be vicryl, which can be allowed to fall off by themselves. I'll just show with the speculum, last size speculum. So this is how I test, sir. I just pass my speculum straight down. If it slides smoothly, then the septum is straight enough and the turbinates are also well in position. I'm just trying to squeeze out and show from the top. Just show from here. Move the, yeah.
Vishwas,
Yes, sir.
when we were students, there was a great professor called
Yes, sir.
Dr. Rangnath. So those days, he used to tell if you have made a septum straight,
yes, sir,
you just drop in your handle of the blade, handle, the handle,
handle,
handle of the knife, knife, BP
okay.
handle.
Reverse hand, okay. Reverse of it.
BP
Okay.
handle without,
yes.
Of course, without blade. You
Yes,
just drop it. It should just drop into the nasopharynx, straight away go down.
Yes, sir. Sir, now you can see it is straightened up. Show the
Very
whole.
good job, Vishwas.
Yes, sir. Thank you, sir.
Very, very good job. Very good job. Your Professor T.M. Nagraj would be very proud.
Yes,
so
sir.
Would be Ullas Raghavan.
Hold it there.
It's a very good job.
Professor Nagraj, sir, groomed me to what I am today, sir.
Yes,
so I owe it
absolutely.
to
I
him.
know it. I know it.
Yes, sir. So I'll start applying the Steristrip, sir.
Yes, please.
Thank you so
And
much,
I
sir.
think you can, cross the mic to Naveen
Yes, sir.
and let him complete. Probably the other side requires a little bit of a fess. Let Naveen complete it.
Yes, sir.
Yeah.
Vishwas, Dr. Sonali Pandit here.
Ma'am,
Very good job.
Good afternoon. Good afternoon, ma'am.
Good
Thank
afternoon.
you. Thank you so much.
Yeah.
Sonali madam, hopefully you liked all the surgeries today. What was on
Yes,
display?
yes, sir. It was peace to watch. I actually I missed it in between, but I'm going to check out again in
Yeah,
between.
you can all bug Chetan for the recording.
Yes, yes. But
He-
whatever
he
I
has
watched,
bu-
it was treat to
He has
watch.
bugged us last 3 weeks, so we can take revenge.
Steristrips, dry gauze piece and Steristrips.
Sponge. Sponge.
Keep the splint ready. Dry gauze piece banta. Cut please.
Naveen,
Wipe off all
Yes,
the
sir.
oil.
might as well do a middle meatal antrostomy.
Yeah, yeah.
There are
That's why I've
polyps there.
infiltrated. I could see
Yeah.
some
Scissors.
polyps here now.
Very good. Kodi ಇನ್ನೊಂದು ಕೊಡಿ.
Yes.
ಅಲ್ಲ ಅದ ಇನ್ನೊಂದು ದೊಡ್ಡದಿದೆಯಲ್ಲ ಕೊಡಿ.
Ball probe. This appears to be the free end of the uncinate, but entire thing is polypoidal. So I would prefer to use the ball probe, directing it inferiorly. Debrider. Straight grasper. Suction. Debrider. Straight glass. So I've debrided the mucosal surface of the uncinate. Just going to take out the bony uncinate. Check my debrider. Now you can give me the 40-degree blade. Suction. Hello.
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 Dr. Girish here.
Yes, sir.
Dr. Naveen.
Yes, sir.
Yeah. We are with you.
So initially we could see some purulent discharge in the nasopharynx at the start of the case.
Yes.
So now it's clear. So before starting the case, we could see some purulent secretions in the nasopharynx.
Yes, definitely. Very much.
So
better.
now we could see this in the right maxillary sinus. 40-degree blade. So I'm just widening the middle meatal antrostomy. Ball probe. Forty-five-degree upturned forceps. Debrider.
Is it a polypoidal mass or cyst in the maxillary sinus?
Sir?
Dr. Naveen, some polypoidal mass is seen. In the
Yeah, it's a polyp inside.
Yeah.
And there was some purulent secretions inside.
Okay.
I'll just put a 70-degree scope to visualize inside the maxillary sinus.
Yes, yes, yes. It's quite
It's a cobblestone mucosa, sir, in the
Yeah, very nice.
maxillary sinus.
I
Third
think
section.
70-degree you are using.
Yes, yes, this is 70-degree now.
Yes, yes. We can see clearly the mucosa cobblestone appearance is there. Edematous.
So this is going to regress with nasal spray. We don't have to strip this mucosa.
Okay. Like post-operative, you want to use steroid sprays?
Yes, sir.
Or we can irrigate with steroid Budecard or
See, for the first few weeks,
yeah.
We give them saline nasal spray.
Okay.
And once after 10 days, once we do an endoscopic cleaning, we can start either on saline irrigation with steroid irrigation, which you said.
Yes, yes.
And then these people are bound to have some amount of allergic symptoms.
Yeah.
So the steroid spray would address both.
Initially irrigation.
Yes, sir.
Then
Yes, sir.
later they can switch on to the sprays because that is more convenient.
Yes.
And we will have a more patient compliance.
Yes.
ये 15 दिन का दिया हूँ, ठीक है, अभी sufficient है अपना 15।
So this is the part of the bulla.
पर already 1 महीने का तो दिया हूँ 60 गोली सब, तो 15 दिन बाद मिल लो आपसे, फिर दवा चल ये गोली का कैसा असर रहता है तो बता देना मुझे।
So this is the retro bulb.
देखो आगे पीछे ठीक है, तो ताकत से अच्छा ये कम टैक्स है, इसका नुकसान रहेगा तो सही, थोड़ा रहेगा तो वो अपने को तो अच्छी है, जिससे अपना जो आवाज और ये कान में आ रही है इसका कैसा फर्क पड़ता है देख। अंशुल ओमिक्स में सीधा रखिए क्या 30
Section check to that. Section 2 कोड़े।
इस दिया
कोड़े section को।
हाँ देखिए हाँ चाचा सॉरी
So again, keeping the superior aspect of the bulla intact, just taking out the polypoidal mucosa in the bulla.
Yes, yes. So seeing the blade is very important when we are using the
Yes.
debrider, right?
Suction. (45-degree) upturn forceps. Sponge ಕೊಡಂಗೆ.
For decongestion in between, you prefer Marasol packs?
Sorry, sir, I couldn't hear you.
For decongestion in between,
Yeah.
Marasol packs you are using?
Yes, yes. So
Okay,
in between, we can keep placing platelets of Merocel. Ball probe.
That is the uncinate move.
Yeah, upper end of the uncinate, sir.
Yes.
Suction. Ball probe. Debrider.
We should be always careful about our lateral limit, right?
Yes.
Incinate is directly attached to lamina
Yes.
papricea
Ball probe.
on the lateral wall.
The upper end of the uncinate.
Yes. Okay.
Sponge. Sponge. Straight grasper. Suction. So here again, this will be the watershed area for me to enter the, to go through the ground lamella. Debrider. Inferior and medial. Sponge. Debrider. So in between decongestion, we can finish off the other work.
Yeah.
So this is the lamina what we are staring at. Bottles. This is the lamina.
Yeah, lamina papricia, very thin bone.
So confirm with eye movement. So there's no dehiscence.
Yes.
Suction. Straight grasper. Here we can also use the medial approach to cortals, to visualize our superior turbinate.
Yes.
Get a sponge. Now this is also a very safe way to approach the sphenoid straight grasper. Sponge. Debrider. So the lower end of the superior turbinate, either you can cut or you can debride. Sponge.
Some polypoidal mass.
Straight grasper.
Looks like posterior ethmoidal polyp.
Sorry?
That polyp arising from posterior ethmoids.
Yeah, it's in the posterior ethmoids. And what else? See, the safe area which we were speaking about is about the junction of the superior and the medial wall of the maxillary sinus.
Yeah.
So now we try to approach the sphenoid. At the same level.
Same level or just below that. We have to follow. Yes.
Okay. So just at the same level and just a little, just a little below. And we saw going through the ethmoids on the left side. So here I'm showing we can go through in a safe way, again going in the medial plane.
Yeah.
Sponge. And as we see, there's a lot of polypoidal tissue.
Yes, yes. We have to clear all those things.
Debrider. So here we are seeing the posterior ethmoids. Sponge. Arteries. You can use a blunt instrument to enter the sphenoid. Sponge.
Dr. Naveen, this is Dr. Rajiv here. Have you used a transseptal approach to sphenoid anytime? Because anyway,
Sir?
we have done a transseptal approach to sphenoid.
Yeah, we
Because,
can do it, sir.
Yeah,
We
have
can.
anyway, we have done an endoscopic septoplasty. So that would be one more safe way to open. the
Yes,
sphenoid.
yes, yes. Again, the transseptal approach. You can just, I just sutured it here. I just taken the sutures here. When I did a septoplasty, I actually showed the sphenoid ostium through the septum here.
Yes, that's correct. So if we keep the suturing to the end, then we could have used that approach also.
Section number 2, actually. When we do a septoplasty, as you rightly said, sir, we can do it. So we showed this. So this is the sphenoid on the left side. And as we saw on the scan, the sphenoid on the right is much smaller. So once we have identified the sphenoid, now the other indication that this is the sphenoid and not the posterior ethmoid is, one is it's the midline and we are not able to see the floor. Debrider. So we can just debride polyps in the tissue anterior to it. Straight grasper. Arteries. So once we have identified the sphenoid, we can proceed with addressing the posterior ethmoids further.
Yes.
So we are safe anterior to the sphenoid.
You know your limits now.
So when you are in doubt, better not to use the debrider,
Ah,
45-degree upturned forceps.
for the beginners.
Yes, yes, yes. This is our lateral limit, as we already saw. This is the lamina, what we're seeing there.
Yeah.
Straight grasper. Yes, sir. Yes, sir. So tactile, we have to feel the bone.
Yes. With the ball probe.
Yes, a ball probe or even our suction, which I'm using here.
Yes. Yes.
They are safer than the powered instruments, debrider. So once I'm clear that I have a bone behind, I use the debrider.
Yes.
Open one cell at a time.
Oh. This is the safe method.
So blunt dissection is always safe. Debrider. And I am continuing to use the 0-degree endoscope itself.
Right.
Debrider. So that's the skull base, what we're seeing there.
Yes. Very clear.
Through the posterior ethmoids, 45-degree upturned forceps. Suction. So we need to remember the skull base is sloping.
Yes.
Divider. Now this is our posterior limit. -45° upturned forceps. Deep breath up. Suction. -45° upturned forceps. Deep breath up. Ball probe. Ball probe. -40° blade. Suction to ಹಾಕಿರಿ. ಸಕ್ಷನ್ ತೆಗೆದ್ಬಿಟ್ಟು ಹಾಕಿ ಈಗ ಕಟ್ ಆಗುತ್ತೆ. Deep 45° upturned forceps ಕೊಡಿ ನಿಮಿಷ. Deep breath. Suction. Okay. -70°. Ball probe. Curve suction. Sanadilla.
Dr. Naveen, excellent surgical demonstration. Really thoroughly enjoyed.
Thank you, madam.
I gotta go now. I have to start my OPD.
Thank you.
Thank you
for
so much. And thanks Alkem and thanks Dr. Deepak sir for inviting me to moderate. Looking forward to meet you all again. Thank you.
40-degree blade. Yes, sir. Ball probe. Forty-five-degree upturn forceps. I'm just going to take out this bony spicule and stop it at that.
Like uncapping the egg there. Huh?
Yeah. Curve suction.
Hello, Dr. Naveen.
Yes, sir.
Yeah, this is Dr. Bhattacharya from Calcutta. I'm afraid I'll also have to leave for my OPD now. Is it okay?
Oh, thank you, sir. Thank you.
Thank you, Dr.
Thanks a lot.
Bhattacharya.
Thank you. And thank you, Alkem, for inviting me. And thank you, all the organizers. It was a wonderful show. Thanks a lot.
We'd like to thank Dr. M.N. Bhattacharya of Kolkata, Dr. Sonali Pandit from Mumbai, and Dr. V. Srinivas from Bangalore for having been the moderators for Dr. Naveen's surgery. Thank you very much.
Thank you. This is Dr. Bhattacharya. Thank you.
Straight suction.
Hello, am I audible?
Give rudder.
Yeah.
Straight back.
Yeah, pressure. Can I go ahead?
Straight suction. Sponge करो.
Dr. Naveen?
Yes, sir.
We are having a lecture here, so we are signing off from your.
Yeah, I'm done, sir. Thank you.
Thank
all.
you very much. It was wonderful work, Naveen. Thank you so much.
Thank you, sir. Even I'm closing. Thank you.
Thank you, Deepak sir. Hello and
We are
good
shifting
afternoon
to Balchandra Joshi right now.
Thank you, sir. Thank you. Hello and good afternoon to one and all. Myself, Balchandra Joshi, Marketing Head for Burgeon Nova Division, makers of Joseph CV, Enzoflam, and Newlog D. At the outset, I take this opportunity to thank Dr. Deepak Alipur, sir. Sir, your expert guidance is always truly making rhinology surgeries easy. And also thanks to Dr. Vishwas, Dr. Naveen for demonstrating some of the finest pieces in rhinology surgeries, which offered many tips and tricks to the audiences.
Final pack करो.
Thanks to our esteemed moderators, Dr. Shashidhar, Dr. Srinivas, Dr. Sanjay Agarwal, Dr. Jayaprakash Reddy, Dr. Harihara Murthy, Dr. M.N. Bhattacharya, Dr. Sonali Pandit, Dr. Islam, whose expert remarks and questions made this workshop more meaningful and interactive. I thank all the dignitaries of Raja Rajeshwari Medical College, particularly Dr. Nagaraj sir, who has been instrumental in getting the KMC credit points for this workshop. Special thanks to HODs and professors of 15 Medical College, where live streaming of this workshop is enabled for knowledge sharing to 375 plus otolaryngology students. Thanks to all the delegates. With over 1100 otolaryngologists live, your presence encouraged and made this webinar a milestone for us. I'm sure this workshop has enriched all the audiences with important takeaways in rhinology surgeries. Your valuable prescription support is encouraging us as always. Thank you very much and have a pleasant day ahead. Thank you, sir.
Recording stopped.